I hope you can hear me. Good morning, all.
We can hear you very well, and go ahead, the screen is clear.
Okay, so I'm going to talk about NCDs and the SDGs. Now, NCDs, non-communicable diseases and conditions. Actually, in a few decades ago, we were not talking about them in our region, in Africa, but today they are there. Today, globally, NCDs kill 41 million people, an equivalent of 70% of all global deaths. And out of these 41 million, 16 million die as a result of premature death. That is dying between the ages of 30 and 69, which is very common in our region. And unfortunately, of all the deaths, 85% of them occur in low and middle income countries where we all belong. NCDs are on the increase. They are increasing very fast. They are increasing at a rate of 17% at the global rate, but in the African region, they are increasing at 27%. So we really, really have to put in efforts to reduce these NCDs. At the global level, we talk of 4 major NCDs. These are cancers, cardiovascular diseases, chronic respiratory diseases, and the diabetes. But in the African region, 3 more were added as major NCDs, and it can be non-communicable diseases or non-communicable conditions. And the ones that are added are mainly mental disorders, sickle cell disease, violence, and injuries. Very, very important in our region. Now, the topic was achieving SDGs in, okay, it's closing, in view of addressing the NCDs. What are SDGs? Sustainable Development Goals. They commit governments to develop national responses. Governments are committed to respond to the SDGs. We have a total of 17 of them, and SDG number 3 is responsible for health, which talks of ensure healthy lives and promote well-being for all at all ages. Under this SDG 3, there are several targets that governments have to respond to. But 7 of them are specifically for NCDs. And these are under target number 3.4 that talks of by 2030, we have to reduce by 1/3 premature death from NCDs. Remember the 16 million there. 3.5 talks of strengthened responses to reduce the harmful use of alcohol. I just saw on an advert on TV 2 days ago or so that allow people to come and take alcohol. Oh, if you get a vaccination for COVID-19, then you'll get a free bottle of alcohol. That is dangerous for you because alcohol and COVID-19 do not go together. By 2020, 3.6 talks of by 2020, we have to halve the number of deaths and injuries from road traffic accidents. Road traffic injuries are highest in the African region, and Kenya is one of the top 10 countries in the world that has the highest deaths from the road traffic crashes. And yet Africa, unfortunately, has got less than 2% of the world's motorized transport. We have to do something. 3.8 talks of achieve universal health coverage. When we talk of universal health coverage, we see that there are conditions that are prioritized. And you find other conditions like, for example, the diabetes. It's like, yeah, yes, you know it is. We have to achieve universal health coverage for all conditions. 3.9 talks of by 2030, substantially reduce the number of deaths and illnesses from hazardous chemicals and air, water, and soil pollution and contamination. This is one of the risk factors for NCDs. Target 3.A talks of strengthen the implementation of the WHO FCTC. FCTC's framework Convention on Tobacco Control. We have to strengthen the implementation, and Kenya is a party, meaning it has ratified the FCTC. 3B talks of support research and provide access to affordable essential medicines and vaccines for NCDs. For example, HPV vaccines and so on. All in all, the major one is reduce by 1/3 premature death from NCDs. Hope you can see that picture, some of the risk factors for NCDs. When we look at this gentleman, he's very happy, but he is chained. He is chained by smoking, alcohol use, sedentary lifestyle by lying on the couch and watching the TV. Those are major risk factors for NCDs. And many more risk factors. For example, here, machines are changing. We can see the thinner the cell phone device that you have, the more you feel good. And yet, the fatter I am, then it means I am living well. Are machines more clever than us? On this particular one, we are even encouraging animals to be sedentary. You can see that motorcyclists carrying an animal there with some 2 individuals. Our animals cannot walk anymore. We want them to move faster. The advert on your right, balanced diet. Look at that balanced diet. Means that a cookie in each hand. Is that balanced diet? And my young lady there, if I'm married and I don't put on weight, my husband is not treating me well. Our culture. Now, there are 2 types of risk factors, modifiable and non-modifiable. The modifiable one includes tobacco use, physical inactivity, unhealthy diet, harmful use of alcohol, and air pollution. We can modify these risk factors. We know that tobacco accounts for over 7.2 million deaths. Of the 41 million deaths, tobacco is responsible for 7.2. Sodium intake, salt, is 4.1 million. We take more salt than what is recommended. And we know that of the 3.3 million deaths attributable to alcohol, 3.3 are as a result of NCDs. While 1.6 million deaths die as a result of physical inactivity. Are we an active nation? Kenya is known worldwide for our marathon runners and so on, but at home, are we physically active? The metabolic risk factors include raised blood pressure, overweight. Sometimes there's nothing you can do with that. Hyperglycemia and hyperlipidemia. And in this one, hypertension is the leading metabolic risk factor for NCDs. Now, NCDs threaten the progress towards 2030 agenda for the SDGs. If we don't focus on NCDs, we shall not achieve the SDGs. We know that poverty is closely linked with NCDs. Poverty is one of the SDGs, and if we don't address it, we may not be able to address the NCDs. Vulnerable and socially disadvantaged persons become sicker and die sooner than the other social people because they are at a greater risk of being exposed to the harmful products such as tobacco that we have mentioned, unhealthy diets, and have limited access to health services. And in low resource settings, healthcare costs are very, very exorbitant for NCDs, and therefore they quickly drain household resources following the exorbitant cost of NCD management. How do we manage the NCDs? In general, we know that NCDs are silent killers. You don't have signs and symptoms until very late. So unless we create some strategies, for example, the wellness clinics, and encourage our people to go for general checkups, we shall end up having very many people with NCDs. We know that the general population is not well oriented, including even the health fraternity. We don't have time to go for general checkups. You only develop serious signs and symptoms when the condition is advanced. It's when you start noticing, wow, what is going on and so on. Once the condition is identified, it requires long-term care. Long-term care is discouraging to people, to the population, if they do not understand what it means, because one wants to go to a health facility, be treated 2-3 days, and you are fine. Not to continue taking medicines for long. So it is our duty to make sure that we educate the general public. I've mentioned the wellness clinics we don't have, and the way our health facilities are. Fewer health workers, long queues of very sick persons. Then I'm on the queue and I arrive and I tell you, doctor, I just want you to check my blood pressure. The first thing I'll be told is you are wasting my time, go away. So we really, really have to look at this. For NCDs, we must create wellness clinics. Issues of social cultural aspect. I have cancer. Now, why do I have this cancer? It's because my neighbor passed by the other day and did not look at me properly. Let us go and educate our people so that they understand what these NCDs are. Do we include traditional healers in the general healthcare system or not? I was in Ghana and they have incorporated traditional healers in the management of the diabetes. Why? Because our people will first go to the traditional healers and be told ABCD. When it is too late is when they come to the health facility. Can we orient them? Can we orient also our general public on this? In general, what I've just said, we have lack of knowledge for the general public. The conditions in many cases have no symptoms. If I have a mild symptom, I have no time of going to the health facility. I may not have money, and therefore I develop this silent killer. I go to the health facility for checkup. Medicines are prescribed for 3 weeks or more, and I'm supposed to come for review, and I'm not well explained to and not well facilitated. I purchase for only 3 days or so. I consume for 2 days and I leave the rest. I'm feeling okay, I have no problem. After 2 years, the symptoms come, but in a bad way. You have stroke, or you have whatever, and you find that you are rushed to hospital. He was fine and he just collapsed. We don't know what the problem is, but the problem had been identified very early as mild hypertension. But since I was not feeling any problem, there I am after 2 years with a stroke and paralyzed or dead. We must act. We must act on NCDs too. We must prevent and control NCDs. Prevent so that they don't come, and control the ones that are already there. If we don't do anything, we have, it will cost us over $7 trillion US between 2011 and 2025. We have only 3 years to 2025. But if we act, we shall spend 170 billion. Why can't we act? This even goes down to the countries. If we don't act, we spend so much. You've seen the age that is mainly affected. 30 to 69 people are dying because of the premature death from NCDs. And those are the people that build the nation. We have to act. How can we do it? We have to put in measures of early detection, screening and treatment of NCDs, and not forgetting palliative care. Very, very important because of the chronicity aspect. Minimize exposure to modifiable risk factors that we've talked about by establishing preventive programs in all sectors, not only in health sector. For example, physical activity. Why should it be only in the health sector? Let all sectors have even a day in a week that this is 1 hour for physical activity. People will feel much better. Multi-sectoral and multidisciplinary approach in addressing NCDs. For example, we are encouraging physical activity. And I want to be walking along a particular road just to do exercise and I come back. There's no walking pavement. If there is, the matatus are using that walking pavement to throw me off. If I leave early in the morning, around 5 a.m., I'm a lady, I can be mugged easily. So security comes in and so on. So you see that managing NCDs is not a health sector role alone. All sectors must be involved. If I've been told that I have cancer, chances are very high that I'll get anxiety, I'll get depression. That's where the multidisciplinary approach comes in. Let the person not just be seen as this one is a cancer case. No, what other issues does this person have? We must therefore strengthen our health systems to effectively address the NCDs. What has WHO done? WHO has developed the Global NCD Prevention and Control Action Plan that supports countries to look at least to domesticate according to the country's needs and address NCDs. WHO has also come up with the technical packages for NCDs, and if they are well implemented, we can reduce and reverse NCDs. Like the WHO pen, I'm sorry, I'll put a lot of acronyms, but if need be, I can share them. The WHO pen is a package of essential NCDs intervention. It's according to the country. What do you think that this is your essential NCD package? We have the Empower that looks at tobacco control, following the WHO framework convention on tobacco control. We have Inspire that looks at ending violence against the children. Shake is the package for salt reduction. Can we reduce salt intake? Replace is a package to eliminate industrially produced trans fats from the global food supply chain. And it's very common for us to say that food from outside is better than our original foods. That is wrong. We must eat our original foods. We have Quality Rights Initiative that Kenya is implementing. This is a transforming service and this is transforming services and promoting rights for mental health care. It's no longer just dumping a mentally sick person there and leaving the person like that. Treat the person with dignity and focusing on the rights of people. We have hearts that look at CVDs in cardiovascular diseases in primary health care. We should not be sending persons with mild hypertension, mild to moderate hypertension to the referral hospitals. Let the lower hospitals be able to manage. SAFER looks at how to prevent and reduce alcohol intake. And active is, we better be active. We have talked about that. We, however, have a lot of challenges. There are so many challenges involved, but if there is a will, we can manage. There is inadequate implementation of the various strategies that have been put in place. As a result of inputs, for example, finances, we have limited data leading to low the prioritization. If we compare ourselves with the HIV/AIDS, for example, HIV/AIDS can say that in location A, we have 10 people that are 10 people who are below the age of 18 have got ABCD. We don't have data for NCDs, very minimal data. So we really have to prioritize this. There is absence of an integrated approach in addressing NCDs. We try this, and when you say that let us integrate NCDs with HIV/AIDS, because we know that management of HIV/AIDS have got high chances of leading persons to get the diabetes, for example. The first thing that you are told is that you want to use their funds. Can we accept to integrate management of NCDs with other programs? There is insufficient human resource for addressing NCDs. This is very common. It's improving, but it's very, very common because one of the things is that NCD is a desert area. Hakuna pesa. There is underfunding of the health systems that give more focus on communicable diseases and curative services. What can we do here so that funding also goes to NCDs that are causing 85% of all the deaths in the world? And yet they are really, really underfunded. We are not looking for NCDs. NCDs are looking for us. What can we do to prevent them? NCDs, I can't see the subheading. NCDs are the leading causes of death in the world. Okay, conclusion. NCDs are the leading causes of death in the world. They are killing 3 in 5 people. Hence, they are a public health priority. 3 in 5. How many are we? Wherever you are, you look at 10 people, 3 in 5 will die as a result of an NCD. NCDs are very costly to individuals, households, and countries with a staggering economic burden. How can we leverage on this? How can we see to it that NHIF is supporting NCDs without preconditions? There is premature deaths from NCDs. However, NCDs can be prevented by changed policies and active engagement, not only in health, but also in other sectors. It is our duty to involve other sectors and explain to them why it is very important for all of us to prevent NCDs. Effective action, including preventive measures, will save millions of lives and avoid suffering. People suffer for a very long time before they die as a result of an NCD. What can we do to make sure that this suffering is not there? Is it possible for us to establish wellness clinics and educate our population that it is important once in a while to be going for checkups just to know what your health status is? Let's implement the WHO technical packages to address NCDs. There are quite a number, I just named a few, but if we address them effectively, for sure we can be able to reduce NCDs. Political and economic engagement of both governments and development partners, including private sector, civil society, and NGOs, is key in addressing the NCDs. There are so many declarations that the political leaders have made at the global levels, including ours. But at the end of the day, very little is done. Can we look at this and ask our political leaders to make sure that it is important to address NCDs? To achieve the SDGs targets, as we have seen them up there, let's all join hands to hold and reverse the NCDs. They are here and they are here with us. Thank you.
I am very happy with the presentation. Very, very prescriptive, advisory, typical WHO as a government, and challenging us at technical level to find how we shall work together, which we must, for the benefit of all of us, the patients and the professionals. Thank you very much. And I would ask Professor Jojo Sanjo to just coordinate the question and answer session for this. Joyce, you're available briefly to answer certain questions. And,
yes, I am.
And then we shall also ask any expert within to make brief comments, but that can be coordinated by Professor George Osanjo. Thank you. I've seen a hand up there. George, can you manage that? Agnes,
thank you.
Yes, thank you, George. Just manage there.
Yeah, thank you. A very inspiring presentation from Dr. Joyce Neto. There are a number of those who are going to pose questions. Please raise your hand and then you'll be unmuted by the ICT team. There are also comments. I'm trying to check. Comments, you can raise your hand. I know sometimes our platform may not easily allow unmuting, so There are lots of comments appreciating the presentation. I'm trying to look for the questions. Many people are inspired by this presentation. So you can also pose your questions via the Q and a platform that we have.
I can see a hand from Alfred Osoti. Don't know if he can be allowed to ask.
Yes, ICT platform, go ahead, please. I'm trying to check from my screen as well.
Thank you. Thank you for the great presentation. I have two questions for you based on your presentation and what we are seeing locally. So what's the legal framework to ensure that some of the barriers that we face are addressed? For example, having walking paths, not building on walking paths, building environment. For example, we'll give you an example in Nairobi now. We are doing constructions and all the pathways are closed. So pedestrians have to struggle, with cars to try and find where to drive. So what's the legal framework that WHO advises countries to have to ensure that we implement interventions to address NCDs? The second comment that I have is where you mentioned the sort of task shifting of, for example, blood pressure control to lower levels. Do we have evidence that if you do that, basically for mild, moderate elevated blood pressures, that you have better outcomes? Or do we have a situation where patients who are predominantly managed at lower levels without supervision from highly trained professionals are the ones that have suffered long-term effects of these NCDs? Thank you.
Thank you, Dr. Neto. You can handle those if you got the questions correctly.
Yes, I've gotten them well. The first one is about the legal framework that the country may be having in place. For this particular one, I'll say that WHO came up with the Decade of Action for Road Safety, and there are 5 strategies to be implemented. And out of the 5, I think 3 of them are by the Minister of Works and so on. So there was a team, a technical working team that was looking at this. At the end of the day, when NTSA, I think, was established, some things changed at the Ministry of Works, and they established, it's not a technical working group, how do I call it? I forget the name. But when they established this, initially they removed Minister of Health from this. So it is, it's, we have talked about it, and Minister of Health is back to this technical team to see to it that it's not only making a road, but a road means a lot. A road has got pedestrians, has motorcyclists, have cyclists, has, children are crossing the road, school-going children and so on, and people who really want to just walk on the pavement. That one, if there is somebody from the Minister of Health on this meeting, can be able to answer that question properly. But we have passed the information to the ministry, and it is up, okay. WHO advises. WHO does not force a government to do ABCD, but advises the government that this is the best way to go. So we have done that, and we hope that this will be looked into. And of course, when you, the experts, come up and start talking, I think somebody somewhere could listen. How can we tackle the task shifting? Task shifting, currently WHO is supporting a program that is taking place in Nyeri County. This program is a management of hypertension closer home. That is how it's titled. It is a project, not a program. It is a project, and it's been going on for the last 1.5, almost 2 years. And from this, we'll want to see, is it feasible? Is it possible for hypertension, for example, to be managed closer home? But all in all, remember, the referral system has to be functional. Because if the referral system is functional, then I don't see a big problem here. Over and thank you.
Thank you.
So I would like to thank very much our presenter for a very insightful presentation that has challenged us to also have a look at the NCDs. Sometimes you get, from the perception in the society that we are looking more at the communicable diseases. We're in the midst of a pandemic. So we also need to focus, given the data that has been presented by Dr. Neto, we have to give sufficient attention and priority to the non-communicable diseases. The next moderators are Dr. Nelson Matu and Dr. Vivian Okech. So I'll let them take over from this point on.
Thank you very much, Professor Osanjo. This is Dr. Violet Okech. We are co-moderating with Dr. Nelson Matu. Indeed, we have really been inspired and informed by the presentation by Dr. Nato. Our next presenter coming up is Dr. Mika Matiang'i, who will be talking to us about frontline health workers improving access to obstetric ultrasound. Dr. Matiang'i has a wealth of expertise in his area, and I will ask him to introduce himself briefly, then he launches into his presentation. Thank you.
Good morning, everyone.
Good morning, Doctor. You're welcome.
Good morning. You are able to see my presentation?
Yes, we can.
Yes, we can.
Dr. Matiang'i, I'll ask you to kindly just briefly introduce yourself before you start with the presentation. Thank you.
Yes, my name is Mika Matiang'i, currently the Dean School of Health Sciences, School of Medical Sciences at the Amref International University, and also the Director of Open Distance and E-Learning in the same institution. I've been a staff, an employee of KNH, and I've also been a partner with the University of Nairobi implementing a maybe funded e-learning program. Thank you. That's the much I can say for now. My colleague Priscilla Ngunju, I think, is in the forum. This is a presentation on a project which we are doing with the Philips Foundation, which is the funder with UNFPA. And also we have Philips, the former Philips Health Solutions, and the non-ecosystem in terms of decentralizing obstetric ultrasound screening to the primary healthcare settings. This project has been going on for the last 1.5 years in 3 counties in Kenya. That is Kajiado County, Migori County, and Kisii County. And now we have added Homa Bay County as the 4th county as well. Currently, we are exploring to implement the same in Vihiga County in the Western. As we are all aware, the World Health Organization expects all pregnant women to access a routine ultrasound screening by 24 weeks of gestation. But in Kenya, currently where we are, is only 25% of women who access an ultrasound screening during pregnancy. So the question is, how do we ensure that the remaining 75% of the pregnant women can access ultrasound screening? The challenge has been we have very few sonographers, and also we have very few radiographers who have ultrasound screening skills. So this project was designed to use a Lumify technology. This is a mobile technology, Android driven, to do ultrasound screening in the frontline healthcare settings. The question was, who can spearhead this intervention? Of course, very debatable idea, but we settled on training midwives, registered midwives to do ultrasound screening within the frontline healthcare settings. That is level 2 and level 3 health facilities. Currently, we are having 14 sites. That is 14 sites where we are having these services being delivered. But given that the service is mobile technology based, the midwives are now able to do even the screening from the households. They are contacted by mothers to go and screen them within the households. So we are using content which has been standardized by the partnership, through the partnership arrangement, and the content has been approved by the various partners in the professional circles to use in training the frontline health workers. At the moment, we are mainly getting the support of the sonographers, the Radiographer Society of Kenya, SOC, in terms of mentoring the midwives. After they finish the training, we first send them content access to the e-learning content, access for 2 weeks. After they go through the e-learning content for 2 weeks, then they attend a physical training for 5 days. After the 5 days training, we pair them with radiographers in those sites. So the radiographers, they mentor them for a period of 3 months, but at some point we taper off the mentorship so that we reduce the level of dependency on the radiographers. And after the 3 months, what we notice that most of the midwives, they start working independently with very minimal remote consultation. Lumify technology is also having another complementing technology, that is React. With the React module, if there is internet access where the midwife is doing services, it is very possible that the midwife can share the images of the mother she's screening with a radiographer who is even in Nairobi or who even is in Mombasa, as long as the internet connectivity is good from both ends. And so that one also provides an opportunity to ensure that where the midwife is challenged in terms of appreciating what is going on in the pregnancy status of the mother, then she can get remote support by the professional radiographer or sonographer. I've given a background on that, and I was to play a video clip before this presentation, but maybe I will do it at the end of the presentation. But it's just to show the voices from the field by the midwives who are doing the ultrasound screening. Remember, I'm talking about screening. I'm not talking about diagnostics. They're not doing diagnostics, they are screening. Just to tell the gestation of the pregnancy, they can tell the location of the placenta, they can tell the amount of amniotic fluid, whether there is a polyhydramnios or oligohydramnios, they're able to measure that. And in most of the cases, they're also able to tell the sex of the baby in case the mother wants to know that status as well. So the picture we're seeing here is a midwife in one of the facilities doing an ultrasound screening in a facility in Kisii County. I think I've given a background of the project and why it was designed by the various partners who are involved. So the truth is that we have less than 1,000 sonographers in the country, and we have about 9,249 facilities. So you cannot, the mismatch is very huge in terms of people or mothers accessing the services. Why we chose on midwives is because they are able to give more than 80% of antenatal services. This is one of the UNFPA findings in 2017, that if you train a midwife very well, she can give more than 80% of the services that a pregnant woman needs in any given settings. The International Confederation of Midwives also expects midwives to be able to detect pregnancy complications. But the challenge we have been having is how can they detect the pregnancy complications unless we give them the skills they need to do so. Otherwise, Currently, the practice is that we do an ultrasound screening in pregnancy only when we suspect a complication. But we don't do it routinely as the WHO expects for all the pregnant women before 24 weeks gestation. I have talked about the partners who are engaged. Currently, it costs mothers only $5 to access the service. But in the counties where we are currently, we are having two business models. One business model is where mothers are paying $5 per day, and the other two counties, mothers are not paying anything at all. They're getting free services, but county governments are supplementing in terms of procuring the supplies which are required to do the ultrasound screening services. That is in Homa Bay and Migori County. The other two counties, mothers have been paying $5. That's 500 Kenyan shillings to access the service. I need to appreciate the importance of stakeholder engagement because it has enabled us to ensure that the project implementation is well monitored, and we are able to meet periodically and look at the challenges and also the gains being made. The end game of this project is to generate evidence which can inform development of a task sharing framework in sonography services, whereby we can allow certain services to be offered within the frontline healthcare settings or the primary healthcare settings. And we can allow other diagnostics to be done in other levels of the health system. But all in all, there is work to be done in every level of the health system, depending on the service providers who are there. I think, of course, this is what is point of care ultrasound services or point of care ultrasonography, called as POCA or referred to as POCAs. Our partner, Aga Khan University, has been doing the same project in Kilifi. And at the moment, they have also introduced mobile obstetric monitoring technology, which we have also introduced in the other counties. In addition to doing obstetric ultrasound screening, we are also empowering the midwives to use mobile obstetric monitoring, whereby they are able to track the progress of a pregnant woman, even for the period she's away from the facility. And the technology is able to measure or gauge the risk of the pregnancy or the risks the pregnancy is facing during the entire spectrum of the antenatal care period. Initially, we started by training 42 midwives from the selected pilot counties. To date, we have now trained 67 registered midwives with the support of the radiographers who also provide mentorship until acquisition of the skills is plausible enough before they are left to do screening on their own. In the interest of the business model, we are grouping the midwives into groups of 2 to 5, and then each of the business unit is, of course, supported by a radiographer. And the money that is charged the mothers, it is part of it is an incentive to the midwife and the radiographer, and the remaining portion is also supporting acquisition of supplies. That is for the counties where we are having the business model that involves mothers paying. In the other counties where mothers are not paying, the service is free, but the county governments are the ones which are doing the payment for the supplies. The end game of this, as I said, is to have a well-informed policy framework and also to see whether NHIF can absorb some of the costs for ultrasound screening within the primary healthcare settings. This will make sure that we are able to meet the WHO requirement that every woman by 24 weeks gestation is able to be screened to know the status of her pregnancy. That is how the technology, is packaged. We only have, you only need a tablet or a phone if you have an Android phone, a cell phone, and also you need a probe. It's just the probe and the mobile phone or the tablet. And of course, we install the software for the ultrasound screening. The other things you need are the supplies. You need the gel and maybe the serviettes, to wipe the mother after you have applied the gel. It is very portable. You can even carry it in the pockets. You can carry it in a bag. And that's why I said in some situations, the midwives are screening the mothers from their residential areas where need arises. Actually, the two sites in Migori, the sites we have in Migori and Homa Bay counties, they are funded by UNFPA. And the sites we are having that are implementing the 500 shillings charges are funded by Philips Foundation, that is in Kajiado and Kisii counties. In the interest of time, in the interest of time, I'll want to progress and point out that up to the month of, this is up to the month of August, the midwives that screened 2,695 mothers. And by this month, we have now surpassed 3,000. By this month ending October, they have surpassed 3,000 mothers. And we do have a mechanism of ensuring that the radiographers who are TOTs in the project, they are tracking whatever activities the midwives are doing, just for the sake of quality assurance. We did an operational study, which has been published already. We have published 2 papers out of this project. And in one of the operational research we conducted, we were having the radiographers rating the skills of the midwives who are in the project. And in a scale of 1 to 5, 5 being excellent, you can see most of the competencies were being rated, between 4 and 5, 4.4 being the lowest by the TOTs who are professional radiographers mentoring the midwives. Evaluating anatomy of the chest, the heart, they can tell viability, the midwives can tell viability of a pregnancy by looking at the cardiac activity, performing the 11 weeks to 13 weeks plus 6 days protocol. These are the parameters which basically that were assessed that were rated by the radiographers pertaining the competencies of the midwives. The lessons we have learned is that midwives are able to learn essential ultrasound screening skills. They may not learn everything. They may not learn everything, but they can learn the essential skills. They can tell viability of a pregnancy. They can tell whether the gestation of the pregnancy, especially where mothers cannot remember their last menstrual period. They're able to tell the placenta location. They can tell the lie, the position of the fetus. They can tell all those things, which are very essential within the primary healthcare settings. Other diagnostics which are more advanced, they can be done in case there is a need in other levels of the health system. And also we have observed that mothers are willing to pay, paying $5, mothers are willing. Some of them, they say, allow me sell tomatoes for 2 days, I'll come back for the ultrasound screening. And we have seen they're able to pay that much, which is much affordable compared to what is being charged in private hospitals, 2,500, 3,000 Kenya shillings and the rest. We have also learned that CHVs play a major role in increasing demand for the service. And that's why we periodically have meetings with CHVs so that they're able to sensitize the households, that we have site services within the sites where we're implementing the project. Mentorship, training, coaching are very critical. You need to have a backup for the midwives, and this in form of professional sonographers, radiographers who keep on tracking whatever they are doing. And we do refresher trainings very periodically to ensure that where they are facing challenges, they are assisted to acquire the right knowledge and skills. So it is one of the critical things that must be done whenever we are using the frontline health workers to do this kind of service. Sustainability of the service depends on the uptake of the service. Actually, so far from the business modeling we have done, it is very clear that the service is sustainable. It is sustainable in the long run, and it can even break even, depending on the volumes of mothers being screened. The higher the volumes, the more quicker the break-even point is reached. And of course, we have also seen that competencies of midwives keeps increasing with the mentorship and coaching they are getting. They keep becoming more confident and they're able to do the screening. We've even seen them going beyond the sites, the pilot sites. They are even going to the facilities, which are 20, 30 kilometers away. They book mothers for a certain day. They go and do the screening there on a Wednesday, on a Friday. And this is improving the quality of pregnancy care within those settings. I can't overemphasize the fact that the drivers, what we have seen driving mothers mostly to come, is to know their gestation of the pregnancy, especially those who conceive unexpectedly. They want to know the position, the lie, the sex of the fetus. Those are the driving issues they want to appreciate. Midwives ultrasound skills were satisfactory, or they are satisfactory as far as they're well coached and well mentored. And this is an opportunity to scale up the services. The conversation we're having right now is how to have these entrenched in the mainstream policy so that we make these services more available and accessible. within the settings. That was our business modeling on how we can make this scalable. But as I said, in a nutshell, yes, it is scalable. And in sustainability, we are looking at either county governments allocating resources for the service, or NHIF, within the Linda Mama services or the Linda Mama policy, being able to ensure that this service is having reimbursements to the facilities where the services are being given. The recommendations is there is need to improve women's knowledge on the benefits of ultrasound screening, because what we have seen is our women in the rural areas, they don't know that this is a service that is important in terms of knowing the status of their pregnancy early enough. And of course, the other recommendation is to keep on building on sustainable business models so that when seed funding is over, we're able to sustain these interventions locally within our health systems. There's also the need for policy framework. I think I've said this, to ensure that the policy framework allows some components of ultrasound screening to be decentralized to the rural facilities. And of course, the other recommendation is that it is high time to have county governments invest in these services in terms of budgetary allocation, so that we have the technology being more available in many facilities in the rural settings. Thank you so much. That is the much I can say for now. Thank you.
Thank you very, very much, Dr. Matiang'i and Madam Priscilla, for that very informative and key intervention in maternal and child health services and promoting healthy pregnancies. Now we'll take questions and comments, speak, or you can also post questions and comments on the chat box. Thank you.
Yeah, I've already seen 2 questions on the chat box from Noel Waithaka. For the purpose of records for later visits, probably and another clinic, do they provide the photos? The Lumify technology, the way it is designed, it keeps memory of all images. So in case you want to share an image with another caregiver in another facility, you can virtually share the images. It keeps memory of the images because before you enter the details of the mother, and it keeps that data, yeah. So you can share if there is a need. Lucy Kanyi, is it possible to train all the midwives interested, as we all live in communities and you may be faced with the situation where you need to confirm some of this, some of what's this? The last sentence is not so clear, but yes, we are still scaling up the trainings. As I mentioned earlier, for example, we have had now an agreement with the Viga County to have the same training done in selected sites within Viga County. So yes, the training is available. If you have a need, what we do is we consult our partners, Philips, and also a UNFPA, who are our partners. And of course, we shall lay down mechanisms on how to do the training where it's needed. Thank you, Raphael, for your kind comments. Victor Duor, how can one acquire this device? Victor, we can talk outside the meeting. I think I can share my contact in case there is a need. You can call, and then on the side chat, I've typed my number there. So Duor, we can discuss this. My phone number is on the chat box. Another question. I think I've answered all the questions on the chat box.
Thank you very, very much, Dr. Matiang'i. Indeed, we are inspired and informed, and we look forward to that initiative being scaled out all across the country for the benefit for our mothers and our children. Let us applaud Dr. Riho wherever we are. Just clap for him. We are very, very grateful, Dr. I hope you'll be able to stay on for the next presentation. And next, our speaker coming up next is Kate Maina.
Sorry. There is one question I left out. Sorry, Chair. Is it Dr. Osoti? Yes, the training is available for all healthcare professionals. Even if you have MOs, even if you have clinical officers who wish to be trained, we can make arrangements. Thank you.
Okay. Thank you very much. I believe we are done. Could we go on to the next presenter? Thank you very much, Dr. Matiang'i. Now I'd like to invite our next presenter, who is Kate Maina-Voli. Kate Maina-Voli is the County Director for Plan International, an organization that advances children's rights and equality for girls. She's passionate about gender equality and believes that the SDG 5 is a catalyst to achieving other SDGs. And as a strategist, Kate has had extensive experience both in adolescent rights and opportunities for adolescents and young girls to reach and speak about the things that matter to them. Before joining Plan International, she was chief of party of the USAID-funded Nilinde project in Kenya, and her role ensured that adolescents and children living with the HIV/AIDS accessed ARVs in order to continue living a full life. Apart from that, professionally, Kate is a Kenyan national. She had her first degrees in education at Moi University. She also holds a master's in business administration from Durham University in the UK. She has more than 20 years experience in her field on expertise. And before joining Plan International, she was also the Sub-Saharan Regional Director for the Educational Development Fund, where she was leading a $40 million portfolio funded by the EU, USAID, DFID, UF, including specific programs for girls' education. Indeed, we look forward to learning and hearing from Madam Kate Maina-Voli, who is going to be talking to us about expanding access to youth-friendly reproductive services. Thank you. Welcome, Kate.
Thank you, Violet. Just to bring us to speed, my name is Lilian Gashirin Konge. I'll be representing Kate Maina-Voli because due to unavoidable, circumstances, she would not be able to join this forum, but the spirit to be with this team was so inspiring. So she asked me to step in. So I'm the SRHR advisor for Plan International. And I am a healthcare provider by basic training, having over 10 years experience in service delivery around SRHR, also around advocacy, system strengthening, both in government, several counties in Kenya, and also in international NGO. So I really beg that you allow us to make a brief presentation in the absence of Voli.
You're welcome. Please go ahead.
Thank you.
Thank you.
All right. I don't know if you can see my screen. Are you able to see my screen?
Yes, we can.
Okay. So Plan International as a broad strategy that has been unveiled in 2021. And in our bold strategy, we are trying to respond to the challenges that have really come to our attention during the COVID-19 pandemic, where we've realized that the health outcome as pertains to SRHR for adolescents and youth is deteriorating at a very alarming rate, partially because of the implications of COVID-19 and also due to systemic challenges that have always continued to challenge our ambitions and our commitment as a country to improve the health and well-being of youth and adolescents. So in our country's strategy, we have a very bold goal, that is to contribute to ending teenage pregnancies and all forms of violence against girls and young women in Kenya. And the map you can see there is a representation of the counties. There are 10 counties where we are active as per now. I know we dropped some of the counties because of the program change. I know we are very well known for child protection and education sponsorship, but with the re-engineering of our strategy, we've had to phase out in some counties. So we are currently active in 10 and pursuing to expand to Turkana and Mombasa, as highlighted in green. So the beauty of this strategic period is that it gave us an opportunity to interact with the youth and adolescents, the duty bearers, the stakeholders, And, you know, we realize there is a great need for an accelerated response that is multi-sectoral to these challenges that seem to be, you know, hindering us from achieving the SDGs, particularly SDG 3 and SDG 5. And it is very important for us because as Plan International, we believe that when we are able to meet the SRHR needs of adolescents and you know, advance their rights, we will be able to achieve gender equality. And in the end, it will contribute to the sustainable development that we are all looking out for. So since it was so important to us, we strategically decided to make significant investments in this strategic period so that we can see a better outcome for the girls, the women, you know, and the youth in general. So we will be supporting positive sexuality education and dialogue as a key investment area, forming part of our gender transformative education, both in school, out of school, and we in dialogue with government to see how that be able to support, you know, that conversation and also the actualization. The strengthening of quality adolescents, gender responsive. You note that we are very particular about gender responsiveness because our programming approach, you know, has a gender transformative agenda in it as a way of creating lasting change, as I'll be able to describe later in the presentation. We're also looking at strengthening support for girls and young women at risk. So we realize the socio-cultural communities that we come from predispose girls to various challenges, especially in crisis situations or humanitarian situations, and also in communities where we have high rates of FGM and child marriages. So how do we support the girls that are at risk of these harmful practices that hinder them from achieving their SRHR, you know, as a key intervention? So to briefly describe our gender transformative approach, we are not doing business as usual. We are interested in uprooting those root causes of gender inequalities and shifting those power imbalances as a way to, you know, give the youths and the young people agency and, you know, confidence to be able to access, you know, their sexual reproductive health services and advocate for them. Now, we realize that in our health system, there's a limitation of access for health services. So we are also exploring multi-sectoral, you know, integration with various programs. And I'm happy when I, you know, was listening to the NCD conversation, it was ringing up in my mind. Now, NCDs are an issue for the young people. So as SRHR, you know, programmers, how do we integrate with NCDs so that we increase the spaces where we are able to target young people, and then we can create the lasting change that we are looking for. So we have a strong component of child protection that is very visible, and we also intend to make it, you know, a point of access that can link to the health system effectively and deliver the interventions that we are looking for. So to this effect, to inform our strategic move, there was an assessment study of youth-friendly services that was conducted in Nairobi, mostly Kibera, Kisumu, Tharaka, Machakos. This included about 105 facilities. And this was a youth-led process, of course, with the support of county governments, health providers, and the facility staff. And, you know, the basis of this was for, you know, we realized that young people are active stakeholders. They are not just passive beneficiaries of SRHR services. So before we embark on investing in expanding the services, we were very interested to know the contextual challenges with the services. There are several you know, challenges that came up, and these challenges have been documented in several research. And also it gave us a perspective of how do we target what facilities with what interventions. And that is work that has been ongoing. I would also mention that currently in the month of November, we're also running baseline studies in the same areas that we operate to give us a glimpse of what is the contextual situation, so that going forward, we are only doing interventions that are showing results and showing value for money, value for investment. So the inflexible facility operating schedules was a cutting across challenge, youth-friendly spaces, counties like the Raqqa, they are more or less ASAL regions. There were big challenges with that. The gaps in provider training were transversing across. The scope of services was wanting from the eyes of the youth. The greatest challenge in all those settings was youth engagement. And I think it is high time as implementers, we look at youth engagement as a key intervention, not an option, so that we bridge the gaps. There was also a key highlight of weak referral linkages. And this is partially due to sociocultural, norms, whereby probably a CHV is not very comfortable directing a young person to go seek a contraceptive. So based on their sociocultural backgrounds. And so you will realize that the gender transformative approach is really the way to go, because we have to create very supportive communities for the young people to feel that they have a chance to go out there and, learn about their rights and achieve that. So in our programming interventions, we have really focused on, improvements that are contextualized. And in building the capacity of health workers, I know we've worked with the Ministry of Health a lot. We've worked with AMREF also on some of this training. And the training, is on youth-friendly services does not stop there. We go a step further to gender transformative programming, such that we are able to take the health providers through what we call conversations that matter, which is a value clarification and attitude transformation training. And once we deliver, we have TOTs in the counties that are able to cascade the same through CMEs and also support visits. It has really taken us, a huge mile, because now it's transforming how the health systems respond to the needs of the young people. We have done the same process with the CHVs who are more receptive. We are seeing more young people coming up for services. And it is an intervention that we are linking to the communities so that they know, they are aware about these social norms and how they can, challenge them in their own communities to create a more enabling environment. I've talked about youth being active stakeholders. It is very deliberate for us. Our partners in implementation, they are youth, young women and girls, for the reason that they understand the issues that affect young people. They know the challenges in the health system. They're the ones that we we create platforms to engage duty bearers for policy changes and all that, and all those interventions. And as I speak, I'm actually joining you from Kisumu, where we have a consultative meeting on the same youths, telling the duty bearers, and this community, the kind of what they need to move their aspirations to actions in regards to SRHR services. Policy advocacy, again, in a gender transformative manner, where the girls are the ones going out there and advocating for, SRHR and gender responsive policies and budget allocations, implementations, and review. For those of us who had a privilege to watch the IDGs, one of our girls took over Mercy Mwangangi's role, and she was able to highlight the COVID-19 pandemic and also bring in the discussion around the shadow, pandemic of adolescent sexual of teenage pregnancies. So such spaces create conversations that young people can now cascade to their own counties and see how their duty bearers, are able to listen to them. These are platforms that we have from the grassroots. And I think when the girls now get that urgency, they are coming out, they are challenging the social norms, they are standing out and going for what their rights. So in terms of quality assurance, we have supported a lot on supervision, which we realized was not very consistent, especially orienting on the teams on the guidelines that exist, the policy that exists around SRHR services, and the process and how they can participate in improvement of those policies. We have also done facility targeted improvements where there were no spaces, especially in Daraka. We have worked with the government to create facilities, and they are up and running, and in a way that the system is able to sustain. In terms of improving monitoring and evaluation, this is an area that we feel the government needs to invest more, because it is cost intensive and it's also time consuming, when we need the baseline statistics, for interventions. I know Plan is not the only organization that wants to, to have a concrete baseline, especially for all age groups, including even the 10 to 14 years. So it's an area that we intend to work with the county governments and national government to see how we are able to, periodically, be able to carry out some of these studies so that, implementers have an opportunity to do evidence-based planning. Now, in terms of innovation, we have an innovation concept that we have been piloting in Kwale. The objective of that concept was to update, to improve maternal health outcomes and improve tracking of health services. So we have particularly been successful in implementing, piloting immunization services, whereby there is a smart paper technology that is converted into digital electronic records, can generate feedback report, consumption reports, all those type of reports that are needed either for monitoring or performance management. So from our assessment of the pilot, it has been found out that it has reduced administration time, sorry for the typo, by 60 to 73%. Data quality has improved from 98 to 100%. It has been shown to be very cost effective. It has been shown to be scalable to all the RAMCA indicators. So, smart forms can be developed and cover all those other indicators. It's also sustainable because, it's a technology that does not entirely rely on electricity. The forms can be printed, before they are needed, and then the upload can be done periodically. So this is an innovation that our team in Kwale program unit have been piloting with the county government. We will be looking out to scale up the pilot to at least 3 more counties. So I think this is an area for collaboration, especially with institutions of learning and other like-minded organizations. So in terms of recommendations, we are alive to the reality that young people have multiple challenges, and we need to increase the spaces where they access SRH services. So the integration aspects is very key, especially in those areas that we've mentioned, especially even in disaster risk management, where we have the drought right now. Are we having any minimum essential packages? Are we having any interventions on positive sexuality? So in Ncds, are we having any SRH integration? I know in our programs we have managed that, especially in the Young Health program. How do we expand those spaces? So the other key, learning that we came across was the significant role of grassroots partnership with girl and women-led organizations. This has really sustained the program during the COVID-19, pandemic, and also the interventions are more successful and the impact is more sustainable because the young girls now are the ones, looking for solutions for the challenges they face in SRHR. It has been a huge success, especially addressing FGM and also addressing sexuality education among peers. So there is need for evidence-based interventions. So as I have mentioned earlier, those baselines. And I think it is a call to all of us to partner and do more research. Like for instance, now the gender transformative approach is an approach we want to research very deeply on, because there is need to invent new interventions so that we are not, repackaging old interventions that are giving us the results that we do not desire. So to this regards, we have a MISA regional research team, and I think some of these like-minded organizations can partner with us on other agendas also on SRHR, and we can advance evidence-based interventions. Youth engagement, I have already mentioned that it cannot be this is the cornerstone of all the interventions, and we have to be deliberate to engage them in policy, in implementation, in evaluation, so that whatever interventions that we prescribe or we invest in, they are delivering the results that we are looking for. So, so for further information, probably around the smart paper technology, how it works, what we've done with it, what kind of research we are doing. These are our pages where you can reach us on. And actually, this is just to mention, in our country strategy, one of our aspirations is to accelerate multi-sectoral response. And we are very open to building partnerships that offer solutions to adolescents, girls, and young women in Kenya. Asanteni.
Thank you very, very much, Madam Konge, for a very informative and inspiring and also very educative about presentation about the sexual health and reproductive services for the youth and how they are very, very important stakeholders. We can take questions and comments. Madam Konge, I don't know if you can see a comment there from Dr. Mecha.
Okay.
About the high levels of teen pregnancies in some counties such as Kilifi and Kwale, and what measures are being taken.
Mm-hmm. Sorry?
Are you able to see the Q&A? There are some two comments, questions there from Dr. Mecha about the reasons for, there's a question there about the reasons for high teen pregnancies in some counties such as Kilifi and Kwale with very high dropout rates.
Okay, let me respond to that. Now, we have, thank you. We have undertaken what we call community dialogues in these specific counties that have been shown to have very high cases of teenage pregnancies. And particularly what we found particularly to be some of the root drivers of teenage pregnancies mostly has been, those harmful social norms. So we have seen in counties like Kwale, where there's high rate of child marriage, Kajiado, Tharaka, teenage pregnancies have, literally they are equally high. And when we look at the FGM rates for Kenya and teenage pregnancy rates, they are correlated. The rates are, the rates are almost similar, translating to the fact that these harmful social practices, in especially those communities where, like FGM is a, rite of passage. So where a girl in, for instance, a girl in Kajiado goes through FGM as a rite of passage, for instance, gets married, that is child marriage. And then now due to those unequal power imbalances, where the husband is probably 60 years, she's just 14, she's not able to, negotiate for her sexual rights. And then, and also the social pressures for her to prove her fertility is bringing a situation whereby all those girls that get into early marriages also, get pregnant in the process. So to challenge some of those norms, we have worked with so many counties, especially the Tharaka Nithi, Kajiado, and some are work in progress to see how we can domesticate some of these policies around FGM, so that the counties can invest in them and also can implement them, so that once we take care of that root cause, then the teenage pregnancy scenario, gives us a better outcome. We have also seen the aspects of socioeconomic hardships, especially because of lost livelihoods during COVID-19. So you realize that in our country strategy, the other significant pillar is on youth employability and employment. So that how do we link, these young people to gain full employment, to increase their resilience, to build their social capital, so that they are not, at risk of transactional sex or exploitation for money, all those kind of risks. There are several other that have come out. Now, our approach has been for the communities to dialogue and find local solutions, and it is bearing fruits. Thank you.
Yeah, thank you, Madam Konge. We are in the interest of time. There's also another question by Dr. Meta about how researchers and other collaborators can partner with you to address the issue about painful periods, endometriosis, and adenomyosis, because period pain has been normalized, yet it really impacts young girls and their reproductive health. And then there are also a number of people who are appreciating the great job you people are doing at Plan International. There's a question about smart paper technology. The one about smart paper, I believe you can respond on the Q&A directly. And maybe just touch briefly on whether there's any work being done about painful periods and adenomyosis, and how we can partner with you before we go on to the next presenter. Thank you.
Thank you so much. So in terms of menstrual health, we have a program under WASH and also SRHR that is, geared at demystifying, those myths and stigma and shame that is associated with menstrual health. The program, targets both boys and girls, so that, menstrual periods becomes, something normal and is not attached to stigma. Now, in terms of research, I think that is an area that we could collaborate on. One of the priority areas that we are working on for research for the FY 2022, for us, FY 2022 is like government, June to June the next year. So one of the priorities, we are looking at those social norms that affect SRHR and those key interventions that have been, that are evidence-based to challenge the social norms and transform the communities. So I think this is an area we can probably reach out and take the agenda forward. It can be done either in Plan Kenya or as a collaboration with our East African, the MESA region, the larger East African region. Thank you.
Thank you very, very much, Mr. Nkonge. Sorry, not Mr. Madam Nkonge. And also all our presenters and participants. We are well informed, we are inspired, we're educated. Kindly share with us your contacts also on the chat, so that if anybody would like to reach out to you for further collaboration. I now would like to hand over to my co-moderator, Dr. Nelson Matu, to introduce the next presenter. Thank you.
Thank you so much, Tim.
You're welcome. We appreciate.
Okay, thank you very much, Dr. Violet Okesh. Thank you very much for the past presenters for great presentation. My name is Nelson Matu from the Department of Dental Sciences. I'll be carrying on the next presentation as a moderator. Our next presenter, I'm going to introduce the next presenter. We have Gloria Kitul. Gloria Kitul, are you with us?
Yes, I'm here, Dr. Matu.
Very good. So I'm going to take briefly and introduce Gloria Kitul. She's a holder of BSc in Food and Nutrition, a Master of Arts in Child Development, and a fellowship in Healthcare Program Management. Gloria Kitul currently is the program manager with the International Cancer Institute. And I would want to give this opportunity to you, Gloria. If you're ready, you can set up your presentation. Then you can introduce your topic and proceed with your presentation. Karibu, Gloria Kichol.
Thank you very much, Dr. Matu, and thank you everyone for this opportunity. I also want to appreciate Dr. Nato for her presentation. I think it actually lays a good foundation for what I'm going to talk about. And so my presentation today is on enhancing healthcare workers' capacity in cancer and other non-communicable diseases care in Sub-Saharan Africa through e-health innovations. And this is a case of International Cancer Institute based in Eldoret, Kenya. My co-authors are Emma Acheng, Caroline Chemweno, Stephen Karuru, Dr. Chizikiti, and Professor Chite Asirwa. And we all work together at International Cancer Institute. As an introduction, we are a non-governmental, not-for-profit organization based in Eldoret. And our main purpose is to expand education, clinical care, and training opportunities in cancer control and research across Sub-Saharan Africa through multi-sectoral collaborations and partnerships with relevant organizations, both governmental and non-governmental. And we have partnered with several counties and institutions in Kenya. So far, we've partnered with over 15 of them. And you can get more information about us on this link. This is our approach to care. The patient, the client, and the community is at the center of the work that we do. Moving on to the main focus for today. So on the background of my study, and I would like us to still remember Dr. Neto's presentation. According to the World Health Organization, Sub-Saharan Africa hosts 11% of the world's population, yet it bears 24% of the global disease burden, and with only 3% of the world health workforce at the front line. And there is a disproportionate burden of disease and extreme shortage of healthcare workers, and especially for specialized care for these NCDs, including cancer. And this threat, the new threat of NCDs, is now worsened by the challenge that we face of poor infrastructure, poor access to care, and even the low capacity of the health workforce. And even for the workforce that is available, it's not accessible to all. Therefore, e-health seeks to bridge the gap of formal education and training through telemedicine and virtual e-learning platforms. This slide depicts the cancer burden in our country, and this has been borrowed from the Global Can report on the Kenya Cancer Country Profile of 2020. And as you can see on the left, the total number of cancer cases versus the total number of cancer deaths is really a worrying trend. And looking at the premature deaths as a result of NCDs, and even the fraction of cancer within this number of NCDs is also worrying. And on the right, the most common cancers we are facing, breast and cervical cancer in terms of incidence, and even in mortality, it's also, they're also high. So on the methodology, in our efforts to expand education, clinical care and training opportunities in cancer and other NCDs control across Sub-Saharan Africa, we have leveraged on telemedicine to build the capacity of healthcare providers. And we did this or leveraged on this more during the COVID era. And how we did it was that through our bi-weekly virtual multidisciplinary tumor boards, these are normally held every Monday between 8 to 9 a.m. East African time, and on Thursdays, 4 to 5 p.m. East African time. and as well as online preceptorship training programs in cancer and other NCDs, and through teleconsultations between healthcare providers across Kenya and even across Sub-Saharan Africa. We enabled quality and timely cancer care become possible. And you can get more on our clinical and non-clinical training programs. You can check out the programs that we have offered and even those we are currently offering on our e-learning page on this link. On the results, so as I mentioned, that we focused on this period that is May 2020 to April 2021, we offered a total of 95 virtual tumor boards, and these were attended by over 7,000 healthcare providers from 21 countries across the globe. And interestingly, we had 16 of them being from countries in Sub-Saharan Africa. And this map just shows the distribution of the healthcare workers, and you can see that the majority of them did indeed come from Sub-Saharan Africa. And so this is our reach as at 30th of April, and I know right now the reach has actually expanded. On the online preceptorship program, we also conducted within the same period, May 2020 and April 2021, we offered 21 unique training programs in cancer and other NCDs care. And we had a total of 578 participants, and 95% of them were actually drawn from Sub-Saharan Africa. And their distribution was such that we had 77% being clinical, and that includes the specialists, 17% non-clinical, and 6% of them being allied healthcare providers. And so far, we've even developed other training programs between April and now, and which have been offered to more healthcare providers. This map shows our training coverage. And so far, we can probably say that we've trained over 2,000 healthcare providers in both the online and even on-site sessions. On the outcomes, the online training platform has provided the opportunity for the healthcare providers in Sub-Saharan Africa to be trained from their locality, and this bridged the gap of cost and distance, which would have otherwise been a hindrance to them advancing their training, and it would have limited them. And we're also happy that we have been able to conduct post-training skills assessment on patient care, and specifically for the clinical courses. We have done this in sample facilities in Kenya. One challenge that we identified, and this was through feedback from some of the participants, that during the online training sessions, they experienced poor internet connectivity, which interfered with their training. And we proposed that actually future trainings could incorporate phone airtime or internet bundle support for selected cases. And as we mentioned, we can actually pair the online sessions or the online training programs with skills training. And this is particularly important for the clinical aspects of the trainings or the clinical courses. For example, breast surgical preceptorships, lip and colposcopy training, histopathology for histotechnicians, just to mention but a few. On the right, this is a photo of lip and colposcopy training that we conducted in Taita Taveta County last year in November. In conclusion, capacity building of healthcare providers in Sub-Saharan Africa in cancer and the NCDs can control indeed goes beyond the formal training, the formal classroom session, and it should include ongoing peer-to-peer mentorship, as well as on-job skills training. The innovative e-learning platform has made it possible to reach more healthcare workers. And definitely this would not be possible if we were only conducting classroom sessions in Eldoret or in the counties that we work in. And finally, the use of a multidisciplinary approach to care while leveraging on e-health solutions has been seen to contribute to improved standards of care, which has resulted in positive patient outcomes for the cancer and other NCDs patients in Sub-Saharan Africa. I would like to acknowledge the following: our Executive Director at ICI, the ICI Offices of Education and Training, Research, Data and IT, the Office of Administration and Finance, the Office of Clinical Care, and the Office of Community Outreach. I would also acknowledge all the ICI staff and faculty, and not forgetting the Kenya county governments that we've partnered with, as well as the county health department's leadership and support, our implementing and funding partners, and all the healthcare providers in Sub-Saharan Africa. So thank you very much, and for any questions or further inquiry, you can reach me on these email addresses. Thank you so much.
Once again, thank you very much, Gloria Kitul. I must say that your topic and the work you are doing is quite relevant and very important to all of us in the healthcare. And we know this by, especially in this time of COVID, most of the training has actually been taking place online. I also agree with you that the online training, one of the advantages and most important outcome is the reduction in cost. And as well, we are able to train quite a number of people because we are able to hold, like now this meeting we have, we can hold about 1,000 people. Quite relevant. So I want to request you that for the question and answers, you stay until the end of this session, so that we are able to take to answer questions together with the rest of, we have another 2 other presenters because of, for the purposes of saving time. So yes, once again, Gloria, we are happy about your presentation. Kindly stay with us until the end of this presentation. Thank you very much.
Yeah, thank you very much. That is okay.
All right. We would want to pick the next presenter. Dr. Zawadi Wambui Ismail. Are you with us?
Yes, Dr. Matu, I'm here.
Very, very good. So I want to take some time briefly and introduce Dr. Zawadi Wambui Ismail. Dr. Zawadi Wambui, she's the holder of DDS, Doctor of Dental Surgery from Gaz University in Turkey. She's also a holder of Master of Dental Surgery in Oral and Maxillofacial Surgery, University of Nairobi. Dr. Zawadi Wambui currently is a consultant in oral maxillofacial surgery at Ebu Level 5 Hospital. Welcome, Dr. Wambui. We look forward to your presentation, and I think you can proceed, Dr. Wambui. The floor is yours.
Thank you very much, Dr. Matu, for the kind presentation as your teacher. Good afternoon, everyone. My presentation is on the clinical characteristics of oral squamous cell carcinoma in Central Kenya. Next. Next. Dr. Njiro, Professor Chindia, and Professor Onyango are the co-authors of this research that I did in Central Kenya. Next. Oral squamous cell carcinoma accounts for more than 90% of all head and neck malignancies. This is according to the global data. Kenyatta National Hospital and University of Nairobi Dental Hospitals are the largest referral centers for patients with oral squamous cell carcinoma. Hence, a lot of research has been done on oral squamous cell carcinoma in those two centers. But anecdotal data from the research centers found that majority of the patients had come from central part of Kenya. So this research aimed at documenting the characteristics at the two sites in central Kenya. This is a clinical pictorial image of a typical clinical characteristics of oral squamous cell carcinoma of an ulcerated lesion with rolled up margins. We usually code the disease according to the anatomical site in the oral cavity using the International Code of Disease, the ICD-10 code. This is a map of Kenya showing the central region of Kenya. Highlighted in red is the counties in which this research was done in Meru and Nyeri, where Meru level 5 hospitals and Nyeri level 5 hospitals are county referral hospitals, which offer oral and maxillofacial surgical services to the patients within the county that they're found, and also the neighboring counties who do not offer the oral and maxillofacial surgical services. Next. Anecdotal data from the research that has been done in Kenyatta National Hospital and University of Nairobi Dental Hospital showed that many patients had come from central part of Kenya. So we wanted to explore the reasons. Is it because central part of Kenya has a vicinity to Nairobi, hence to vicinity to the research centers, or could there be other reasons? So the variables investigated in this research included the age, the gender, occupation, education level of the patients, the associated risk factors the patient had, the clinical characteristic, and the histopathological differentiation of the disease the patient presented with. The analysis was done. Next. Analysis of the data was subjected to descriptive statistics of the demographics of the patients. Measures of central tendencies were done, and test of significance using Fisher's exact test, the t-test and chi-square test were done. Analysis was done using the SPSS version 25. Next. This was a hospital-based descriptive study that was done from March to June of 2020, and a convenient sampling of the consenting adults with histopathological confirmed diagnosis of oral squamous cell carcinoma was done. Next. The inclusion criteria was consenting adults with a histopathological confirmed diagnosis of oral squamous cell carcinoma. Exclusion criteria were patients with concurrent malignancies and also metastatic tumors. Data collected included the demographic characteristics, the clinical stage of the tumor anatomical site, and the histopathological degree of differentiation. 53 participants were included in this study, and as you look at the table of interest, you find that 92.5% of all the patients included in this study were aged above years of age. In terms of gender, the male to female ratio was 1.2:1. Next. Of the risk factors associated with the disease, we found that the combined alcohol and tobacco use, which is known to increase the chances of one getting oral squamous cell carcinoma by 8-fold, was the highest at 37.7%. But when you break down the associated risk factors, you find that alcohol was the main risk factor associated with the disease in central Kenya, followed by tobacco, and the least was Mera at 9.5%. But of major interest in these results is that 39.6% of the patients who were included in the study had no commonly identifiable traditional risk factor associated with oral squamous cell carcinoma. Next. This is a clinical picture to show the anatomical sites where we found that the buccal mucosa had the highest, was the most common anatomical tumor site, followed by the tongue, and the least common tumor site was the palate. Next. In terms of the clinical stage of presentation, we find that in the back, we find that the T stage, unfortunately, was the most common clinical stage of the disease. But when you look overall at the bar graph, you find that early stage disease, which the T1 and the T2, comprised of 35.8% of the patients, whereas 64.2% of the total patients who were included in this research had a late stage presentation at the time of diagnosis. Next. According to the broadest classification of histopathological differentiation of oral squamous cell carcinoma, we found that the well-differentiated oral squamous cell carcinoma, together with the moderately differentiated oral squamous cell carcinoma, was the most common histopathological differentiation, each at 37.2%, and the least common histopathological differentiation was the poorly differentiated oral squamous cell carcinoma at 25.6%. Next. This is a box and whisker plot to show the patient delay and the diagnostic delay. Patient delay is defined as the time between the patient first noticing the lesion to the time of contact with the first primary healthcare worker, and diagnostic delay is defined as the time taken between the first contact with the primary healthcare worker to the time of establishing a definitive diagnosis. So we find that 94.3% of the patients included in this study had a patient delay of less than 6 months, which means they presented at an early stage of the disease, whereas the diagnostic delay of up to 69.8% of the study participants had up to 3 months of diagnostic delay. Next. When you compare my study to the other studies that have been done in Kenyatta National Hospital and University of Nairobi Dental Hospital, you find that in terms of age and sex distribution, the disease presented with the same pattern, but in terms of histopathological differentiation, you find that the most common histopathological differentiation was the well-differentiated oral squamous cell carcinoma, whereas in our study, we found both the well-differentiated and the moderately differentiated oral squamous cell carcinoma as the most commonest type of histopathological differentiation in the area. Next. In terms of the commonest associated risk factor to oral squamous cell carcinoma, we find that the studies done in Kenyatta National Hospital and University of Nairobi Dental Hospital, tobacco was the most common risk factors, whereas in our study, we found that alcohol was the most commonest risk factor. In terms of the patients who had no identifiable risk factors, we found a higher percentage of patients who had no identifiable risk factor associated with the disease. Tongue seems to be the most commonest tumor site in the studies done in Kenyatta National Hospital and University of Nairobi Dental Hospital, whereas in our study, we found buccal mucosa to be the most common tumor site. And of interest in the buccal mucosa is that we found that 50% of the patients who presented with the buccal mucosa tumor site had no identifiable risk factor as the risk factor associated with that disease. In terms of presentation of the disease, we found a higher percentage of patients who had an early stage disease, hence a curable stage of the disease, and a lower percentage of patients who had late stage disease as compared to what has been done in Kenyatta National Hospital and University of Nairobi Dental Hospital. Next. Of interest in this paper is the fact that we found that 39.6% of the patients had no traditional identifiable risk factors, and 81% of them were females who were aged between 60 and 69 years of age, who had attained a primary level of education and were small-scale farmers. So could these factors be what associates the patients to the disease, or are there other risk factors that are associated with the disease in the region? This is an area of interest to be researched on. Alcohol, as I said, was the most commonest identifiable risk factor associated with oral squamous cell carcinoma in central Kenya. Patient delay of less than 6 months was found, hence meaning that patients present with the disease at an early stage of disease, which is an encouraging factor to all clinicians who usually see these patients. But unfortunately, the diagnostic delay of up to 3 months leaves a room for research interest in order to understand why it takes up to 3 months for a patient who was presented to the hospital to get a definitive diagnosis. Next. This is a picture of Mount Kenya as taken early in the morning by me. It shows the beauty, I think, depicts the beauty of the region of central Kenya. And I'm hoping that by you seeing this picture, you may travel down to central Kenya and come and enjoy the scenic beauty of this region. Asanteni.
Right. That was a great presentation, Dr. Zawandi Wamboi. And I must say it's quite relevant. I believe I also come from central Kenya, and I know cancer is actually causing a lot of havoc. And for you to gotten the opportunity to investigate why this phenomenon is there in central Kenya, we can commend you for that. I would want to request you as well, you stay on for the question and answer by the end of this session. Thank you very much, Dr. Zawandi Wamboi. I think,
thank you very much, Dr. Matu.
Karibu. We'll now proceed to the next presenter. I'm going to introduce Dr. Mwitwiri Muriuki. Dr. Mwitwiri Muriuki is a holder of BDS, University of Nairobi. He's also a holder of Master of Dental Surgery in Oral and Maxillofacial Surgery. Dr. Mwitwiri Muriuki is currently a consultant in Oral and Maxillofacial Surgery based at Meru Teaching and Referral Hospital. Dr. Muriuki, I know you are with us. You are ready?
Yeah, I'm ready.
Dr. Muriuki, you can introduce your topic and please proceed with your presentation. We still have time. Don't rush the presentation. We still have time for you. Please proceed, Dr. Muriuki.
Okay. Sorry, I'm having problem putting up my slide. But I'm
okay. ICT.
Yeah.
ICT. You can help Dr. Muriuki. Dr. Muriuki, is your presentation with the ICT or you have you're presenting from your own gadget?
ICT has it.
Okay.
From the emails. I don't know.
Okay. There we go. Dr. Muriuki, you can see the presentation?
Okay.
You can see it, eh?
Yeah.
Okay, fine. Please proceed.
Yeah. So the title of the research that I'm presenting is Quality of Life of Patients with Oral and Oropharyngeal Squamous Cell Carcinoma at 2 institutions in Nairobi. So as Dr. Matu has introduced me, I'm Dr. Mwitwiri, and my co-authors in this study is Dr. Njiru, Dr. Odhiambo, and Professor Onyango. So I'll start with defining what quality of life is. And according to WHO, it's an individual's perception of their position in life, taken in the context of their culture and value system in which they live and in relation to their goals, standards, and concerns. So head and neck cancer is the 6th most common cancer worldwide, and 90% of these cancers are actually composed of squamous cell carcinoma. So majority of the patients that we usually receive for treatment, they usually present to us at a very advanced stage of disease. And you can see after treatment, especially in surgery, they usually have a lot of defects that they have to live with, and also altered functions, and they feel socially isolated and all that. So all those factors usually lowers their quality of life at a very big scale. And unfortunately, less emphasis right now is being put on assessing these patients' outcome based on their own experience and subjective feedback. So we find that the main predictors modifying quality of life in these cancer patients is the site of the lesion where the cancer is, the TNM staging, and their treatment modality. So next here, I have a picture of one of these patients who presented to us at a very advanced stage. As you can see, the lesion is involving the cheek, the lower lip, and the mandible deeper in. So already this patient, by the time presenting to you, they have a very low quality of life because of various problems. And for this one, the treatment will be surgery and radiotherapy. So already, because after surgery, you need a lot of reconstruction and all those things. And this thing is on your face. You cannot hide it. It's not like the other body parts. So you can imagine the kind of problems this patient might continue bearing even way after treatment. So the aim of the study was to determine how disease and patient-specific factors influence their quality of life, and also to demonstrate how quality of life changes following treatment. For methodology, the study area was in oral and maxillofacial surgery and oncology departments, both at Kenyatta National Hospital and University of Nairobi Dental Hospital. The study duration was from August 2018 to June 2019. And the study design was a descriptive prospective study. The patients' inclusion criteria was patients who are diagnosed with oral squamous cell carcinoma and who had consented to participate. And the exclusion criteria was patients with prior treatment for oral squamous cell carcinoma. So quality of life scores were taken like before treatment, and then 3 months post-treatment. That is for those patients who had qualified by that time. So for data collection, we are using University of Washington Health-Related Quality of Life Questionnaire version 4. So this questionnaire, we had to translate it to Kiswahili so that majority of patients would be able to participate and be able to verify it after that. And from that questionnaire, it was very conclusive. It was able to address most of the issues these kind of patients face. And as you can see, there were questions asking about how they rate their pain, their appearance, speech activity, nutrition, swallowing, chewing, shoulder mobility. So for shoulder mobility, especially for those patients who had undergone a radical neck dissection and spinal accessory nerve sacrificed, they are the ones who usually had this kind of problem. So you go to the results. So we are able to recruit 71 participants. 42 of them were male, 29 female, the male to female ratio of 1.4:1. And the age range was from 25 to 88 years. The median age was 56 years. And out of these 71 patients, 37 were able to participate in the second review 3 months after treatment. The reason for that is that we lost 14 patients. They died before the second interview. We further lost 6 other patients, but those ones had already completed their second interviews. And then 9 patients were lost to follow-up. We couldn't trace them. And 11 patients had not completed their required 3 months after treatment due to treatment delays. So when you look at the tumor stage of the patients who presented to us, interestingly, majority of them presented at advanced stage of cancer, that is stage 3 to 4, and only one patient was at stage 2. And the main reason for this occurrence, according to the patients, the way they are reporting, so some of them said they are unaware of the seriousness of the disease earlier on, so they waited until it was a bit late. And others were saying that their inability to access timely and appropriate treatment due to financial constraints. Then there was an issue of diagnostic delay, and we found like that 1% of these patients had delays by their primary clinicians due to initial misdiagnosis. So majority of these patients were being treated for infections, oral infections, and they were on antibiotics and analgesics. So this is a table showing the treatment that was offered to these patients. So in the second column, this is the initial treatment plan for the 71 patients. But you can see in the last column, the third column, those are the numbers of the actual treatment that this patient had gotten when we are surveying them at 3 months post-treatment. So of course, you can see the difference in numbers. For example, when you look at those patients who are supposed to have surgery with adjuvant radiotherapy, by the time we are concluding the study, only one patient had finished 3 months post-adjuvant radiotherapy. And we found out some reasons for that. So a bit of them that had delays because of complications from surgery, so it was delayed. But majority of them didn't have those kind of complications, and the main reason was delay from the radiation oncology unit at Kenyatta National Hospital. As you know, because of the congestion, there's a lot of patients there and sometimes can be very overwhelming. So on average, we found these patients were taking 14 weeks before they could start adjuvant radiotherapy. And the recommended time is usually between 4 and 6 weeks for you to get optimum results. For those patients who had required radiotherapy with or without chemotherapy as their primary treatment, for them they were taking around 10 weeks before they could start the radiotherapy. So when you look at in general some of the scores that we got, so the pre-treatment quality of life scores for the 71 patients was on average was 61 out of 100. And then when we compare age, gender between for age between the younger patients and elderly patients, there wasn't that much difference. Same thing goes for gender, there wasn't that much difference when it comes to quality of life between female and male. Now for the 37 patients who are able to participate in the second interview, so their quality of life improved, slightly improved, that is from 68 to 72 scores. This is the table showing quality of life scores per anatomical site. So in the third column, you can see these patients with at the bottom, the patient with tongue-based lesions, they had the lowest quality of life as compared to other sites. And when you come to appearance, how they're assessing how they appear, those patients with the lower lip, floor of the mouth and cheek lesions, they are reporting their scores to be the lowest compared to the other sites. Following treatment, the patients, they reported they had a slight decrease in how they assess themselves in terms of appearance. There was a slight decrease overall, whether in surgery or radiotherapy. Then when we look at pain, here there was a significant relief of pain 3 months after treatment for all these patients, whether it was surgery or radiotherapy. And in general, they were reporting improvement when it comes to pain. Another thing about pain, we found that 39% of these patients reported to have severe pain. That is more than a third of them. And we found there was a link between these patients with severe pain and generally their mood and anxiety. They were also linked with low mood and anxiety when you look at the points when you compare. Other factors like chewing, of course, patients who have lesions in the tongue and the jaws, they're reporting worse scores when it comes to chewing. When it comes to swallowing and speech, patients with tongue lesions are the worst scores. This one is illustrating how the patients who are rating their taste and saliva function. And majority of these patients, the changes that were drastic were those patients who are treated with radiotherapy as expected. So you can see the taste function was reducing by almost 2/3 and saliva by half. When it comes to mood and anxiety, there was a significant improvement in this function, mood and anxiety. It improved from 45 points to 76 points. So by the time at 3 months post-treatment, these patients were rating to have better moods. Last, before I come to conclusion, I thought I must address these patients who were deceased patients during the course of the study. Like I said, there were 20 of them out of the 71 that initially started the study, and the mean age was 62 years. So 5 of them died from post-operative complications, 7 died while undergoing radiotherapy, 2 patients died from residual tumor regrowth, and 6 patients died while waiting to start treatment. So as conclusion, approximately 99% of these patients were presenting at a very late stage of disease. We've been able to see from this study that the quality of life of these patients after treatment was improving, although slightly, despite the side effects they were having. At that, more than that of these patients that were in severe pain upon presentation for treatment, and they had a high level of anxiety and depression, like I had said. And also to note is the delays before proper diagnosis and also delays in treatment, especially for radiotherapy. So maybe the recommendations that we can draw from this study, we need to increase public awareness so that the patients, the general population, can be able to know and pick these lesions early on, and also to improve primary care facilities so as to aid in early diagnosis and referrals. We need to expand our cancer treatment facilities. Majority, I know by now, some of our county levels, we have cancer treatment centers, but not so much equipped. Like right now, we have very few radiotherapy centers where these patients can access treatment. And of course, good patient selection for those patients who need radical treatment to avoid this kind of early mortalities. And lastly, more research, especially in our local setup on oral cancer patients, because we don't have a lot of this literature when it comes to outcome, how these patients fare on following treatment. Thank you.
Thank you, Dr. Muriuki. Mercy, that was a great presentation, quite relevant. And thank you for the information you have given us. We'll take now this opportunity to address the questions that or comments that the attendees have. And I hope Gloria is still with us.
Yes, I'm here.
Good.
Yeah.
So there's one question that is in the Q&A section. I want to read it to you. Maybe you can give us some comment. Thanks for the good work, Gloria. The question is, what steps are you taking, especially as a nutritionist, to sensitize communities on the importance of food quality in cancer prevention? That question is from John Bagger. Gloria, you can proceed and.
Okay, thank you.
Yeah.
Thank you, Dr. Matu. So, John, thank you very much. I know there is a big gap in oncology nutrition in our country. And so what we are doing as International Cancer Institute, we work with the healthcare providers in our partner sites. For example, if it is in Taita Taveta, in Nandi, in Makueni or Meru. And so when we are holding community awareness events or even screening events, we engage a multidisciplinary team where we even have the nutritionists taking part in the activities. We even have social workers and other cadres of healthcare providers. And so even during joint clinics that we hold with the counties, we have health education sessions. And they vary. Each time we have different topics and different presenters. And so we engage the nutritionists on the ground and other healthcare workers who are able to provide health education to the clients, to the patients, and even to the communities. But there is need for more capacity building of these healthcare workers so that they're able to pass the correct message to the communities. Thank you.
Okay, thank you very much, Gloria, for that great response. I think because of interest of time, you will not take any other question for you.
Okay,
now proceed.
It's all right.
Thank you, thank you.
Thank you very much.
Yeah, we are now going to proceed to Wambui, Dr. Zawandu Wambui. I don't know whether there is any question. Anybody who want to pose a question to Dr. Wambui can raise your hand. I think I cannot see any question, but I can personally pose a question to you. Dr. Zawandu Wambui, are you with us?
Yes, Dr. Mato, please go ahead.
Okay. Now my question is, you have this finding that there is a lot of cases of oral cancer in central Kenya.
Yes.
And you looked at the risk factors, and I think you narrowed down to alcohol as the main risk factor. Is that correct?
When you look, Dr. Matu, at what we found, we actually found like combined alcohol and tobacco, alcohol alone, mira alone, tobacco alone, alcohol and mira, alcohol, tobacco and mira. But when you break down those figures in terms of alcohol, tobacco and mira, you find that half of the patients, who are 50.9% of these patients, had alcohol as a common risk factor associated with oral squamous cell carcinoma.
Okay.
Then was followed by tobacco, and then mira was the least common.
Okay, because my question, maybe this is a work in progress. In terms of the use of these risk factors, probably you might need to compare the central Kenya and those other areas that don't have high prevalence of the cancers. Maybe do you have answers, or do you think it should be work in progress?
The only comparison you can do about risk factors associated with oral squamous cell carcinoma is the fact that you know that Kenyatta National Hospital and University of Nairobi Dental Hospitals have been the main referral centers for patients with oral squamous cell carcinoma. So most of the research done around oral squamous cell carcinoma in Kenya have been done in those centers. So the only comparison you can do is of those centers and now in central Kenya. And of interest is you find, if you look at, there's a slide where I show that one of the papers that was done in Kenyatta National Hospital, University of Nairobi Dental Hospital, which looked at the risk factors. They found tobacco at 73% had tobacco as the associated risk factors, which was followed by alcohol. But now we are finding in Central Kenya, alcohol is the most commonest, followed by tobacco.
Okay, great for your answer. Now, I would now want, if there's anybody who wants to pose a question to Dr. Muriuki. Because of interest of time, we only want to take one question for each presenter. Anybody would want to ask any question to Dr. Mwetwiri? Okay, I see like there are no questions for Dr. Mwetwiri, and I want to take this opportunity to thank once again Ms. Gloria Kitul, Dr. Zawandi Wamboi, and Dr. Mwetwiri Muriuki for taking time from your busy schedules to prepare this kind of presentation. It takes quite a lot of work, so feel much appreciated, and thank you very much. In conclusion, finally, I want to end this session. We have taken quite some time. The next session resumes at 2. We are a bit sorry about the delay that took we have taken quite a lot of your time. Thank you very much, participants. We meet here back at 2 p.m. sharp. Thank you very much.
Level of care. We have two types of referrals. We have the emergency referrals, and then we have the cold referrals. So emergency referrals, generally, we have a hotline which staff are able to access, and they call. They are also advised on what they can be doing as they're referring the patient. Then we have the cold cases, whereby anyone who has a referral letter, they go to the clinic, respective clinic. The referral note is looked at, and an appointment is given for those patients to be able to access our services. We are one of the few units in the country, public hospital, that's able to offer laparoscopic surgery. So we've been doing laparoscopic hysterectomies, we've been doing tube
fractures. And these pelvic fracture urethral injuries ultimately lead to posterior urethral stenosis or posterior urethral strictures. Pelvic fracture urethral injuries arise from high energy trauma, such as road traffic accidents, fall from heights, severe pelvic compression, or fall in a ditch or a pit, or just assault or industrial accidents. These injuries, most of the time, don't occur in isolation. They may be associated with injuries to pelvic organs, other pelvic organs, or they may be associated with other abdominal organs. So it's important to recognize this association and manage both conditions simultaneously. The physical signs are variable and depend on the time that has elapsed from the injury time. So prompt recognition, comprehensive and appropriate management is imperative. Now, pelvic fracture urethral injuries rarely cause mortality, rarely lead to mortality, but they cause significant morbidity. Significant morbidity such as urethral strictures or stenosis, which we shall address in this presentation. Significant morbidity such as incontinence of urine, erectile dysfunction, or fistula formation. Which part of the urethra anatomically are we talking about? We are simply talking about the posterior part of the urethra, which technically speaking is a very difficult area to find yourself working in. This posterior urethra is a membranous part of urethra. So these injuries occur just around the bulbomembranous area, as shown in that foregoing diagram. This area is susceptible to injuries because of close proximity to bones. So when the bones get broken, even the soft structures of the urethra also are concomitantly injured. If the ligaments are avulsed, like the puboprostatic ligaments or other ligaments, like the perineal membrane, even the urethra goes with it. And this area is very unique because it's least protected by the spongy tissue or even by the prostate parenchyma. And furthermore, it's a very short area, occupying like about 1.5 centimeters. And it is the least distensible part of the urethra. It doesn't distend much compared to other parts. Pelvic fracture urethral injuries have lots of classifications in application, but the one commonly used is the American classification, as shown in that slide. I'll not go into it because of interest of time. The hallmark of diagnosis is a good history and physical examination, coupled with imaging by way of plain radiography, retrograde urethrogram, and CT scan in a few select cases where you suspect concomitant injuries with other pelvic or abdominal organs. In a few cases where you anticipate management by primary alignment, it may be necessary to do cystoscopy. That picture shows a plain radiograph which will show you the fracture pattern. The fracture pattern in itself is very telling. If you have both pubic rami fractured, if you have unstable pelvic fracture, if you have Malgene kind of fractures, then most of the time, these fracture patterns will be associated with the urethral injuries. And when you put in contrast, when you're doing retrograde studies, it shows extravasation of dye. So if there's extravasation of dye, you just have to suspect pelvic fracture urethral injuries. And when they heal, they lead to fibrosis, so that there's separation of proximal from the distal segment with an intervening area of fibrosis that forms a stenosis of the urethral stricture. A brief algorithm on the management. When you are managing this patient, ask yourself whether this is a stable patient on my hands or unstable patient. If it's unstable patient, you simply resuscitate this patient, put in a suprapubic catheter in the bladder, and then leave the rest of the management later on when the patient has improved. If it's a stable patient, you look at the radiograph that you've done, the retrogram, the retrograde urethrogram, the one that incorporates the use of contrast. You want to see if there's extravasation and if there's evidence of rectal or bladder injury. So if there's evidence of rectal or bladder injury, then you have to do open repair of those injured organs and do realignment, open realignment. But if those other organs like the bladder and rectum are not injured, then you have two lines of management. You can put in a suprapubic catheter, wait for stricture or stenosis to form, and do urethroplasty. The other option is to do endoscopic realignment. You have to use an endoscope from below and another one through the suprapubic tract to shift the urethra that may be diverted to the normal course, and then wait for healing to remove catheter. If the stricture forms, you deal with it as it forms. If it doesn't form, then you remove the catheter for good and follow up the patient. So there are two basic lines of management, either suprapubic catheter or endoscopic alignment. Now, urethral stricture is a very common complication of these two lines of management. But the suprapubic catheterization leads to more stricture formation as opposed to endoscopic realignment of the urethra.
You have 5 minutes remaining.
Performed a study between 2015 and 2019. This was a prospective cohort study carried out at the Kenyatta National Hospital. Our objectives was to compare the efficacy of suprapubic catheter and compare with endoscopic alignment from below using an endoscope to realign the urethra, or just simply put in a suprapubic catheter. So we aimed at comparing the two lines of management. Then we looked at also a secondary management where we are looking at the morbidity or the stricture complications arising from the secondary management, those who form a stricture after alignment or a stricture after suprapubic. What is the effect of our management on those strictures? Suffice to mention that the research was authorized by the ethics committee. The inclusion criteria of stable patients 18 to 80 years old with normal erectile function before injury. Excluded were patients who are unstable and ones who failed to consent. Our study recruited 95 patients. Of these 95 patients, 55 were given management by suprapubic catheterization and 40 received endoscopic realignment. Catheter was left in situ for 4 weeks, and when it was removed, there were measures carried out to assess the patency of the urethra, such as the prostate symptom score, the flow rates, or patient-reported outcome measures. In a few select cases, a cystourethrogram was performed or cystoscopy to test the patency of the urethra. The patients who failed primary management by SPC or suprapubic catheter or realignment underwent delayed urethroplasty 3 months later on. Delayed urethroplasty was by excision and primary anastomosis or by substitution use of graft from the buccal mucosa area. Patient was followed up to 36 months. Outcome measures were urethral patency by anatomical physiological measures, and secondary outcome measures were erectile dysfunction, urinary continence, fistula formation, and urinary tract infection. That is a picture of the process of endoscopic alignment in application. There's a suprapubic approach and urethral approach. So 2 endoscopes, the primary surgeon and his assistant. And the ones who failed alignment later on delayed treatment by excision primary anastomosis or substitution by way of graft was performed. What were the results? Of the 55 patients who had suprapubic catheter inserted, only 3 of them were successful in resuming spontaneous voiding after catheter removal, but 52 failed. So the failure rate was 95%. So 95% of the patients went on to develop urethral stricture and were subjected to urethroplasty. Of the 40 patients who underwent endoscopic realignment, 9 were successful, but 31% developed urethral stricture stenosis and were subjected to urethroplasty as a secondary treatment strategy. Of the outcome, the baseline characteristics were as follows. The average age was 30 years. The average stricture length was 2.2 centimeters. The ones who had suprapubic catheter, they had a longer stricture of 2.8 centimeters. The ones who had endoscopic realignment, the stricture was shorter at 2.2 centimeters, and this relationship was statistically significant. The success rate following primary treatment was 5% for suprapubic catheter and 22% for endoscopic realignment, and this relationship was statistically significant. For secondary management, the ones who failed primary management and were subjected to urethroplasty was 65%. That's about 2/3 in the ones who had the suprapubic catheter at the beginning, and half for those who underwent who failed management by endoscopic alignment. Now, these tables are showing that these urethral strictures are very common in young age groups from 18 to about 34. We have 80% of the patients from 18 to 34. So this is an affliction of very young people in the community. Etiology, what would be the cause of these pelvic fracture urethral injuries? Most of them are motorcyclists, the borders. Falls are number 2, and then pedestrian injuries or injuries of passengers in motor vehicles. So you can see from this etiology that most of it are caused by trauma, which is preventable, and mainly it comes from road traffic accidents. I'll proceed to other slides and make a summary as follows: that the stricture length was shorter for suprapubic catheterization, shorter for endoscopic realignment, longer for suprapubic catheterization, and the success rate was better for endoscopic realignment compared to suprapubic catheterization. And both relationships were statistically significant. There are complications arising from this line of management, and the commonest was urethral stricture followed by urethral incontinence, orchitis, erectile dysfunction, UTI in that order. There was no significant associated morbidity, and there was also no significant social habits such as smoking or alcohol consumption that would impact on the outcome. So in terms of complications, the urethral strictures were common, followed by urinary incontinence. As for discussion, the average age of 30 years is in keeping with the age distribution for among these similar conditions recorded elsewhere by other researchers. They tend to affect a younger age group, 18 to 33, or 23 to 38 in other communities. And the outcome, like I said, if you put in a suprapubic catheter, the risk of stricture formation is higher than if you do endoscopic alignment. And this is in keeping with studies done elsewhere. As for delayed urethroplasty, if you do delayed urethroplasty in those who had suprapubic catheter, the results are slightly better than in those who had endoscopic realignment. And this is in keeping with studies which are done elsewhere. And in a paper that we did and reported in Bali Medical Journal in Indonesia, it showed that suprapubic catheterization, in fact, will give you better results than if you did endoscopic alignment when you are performing delayed urethroplasty. This study, like other studies of this nature, would have limitations in terms of patient selection, selecting patient for the right treatment on the basis of X-ray. These X-rays are done in an emergency setting, and it's very difficult to get correct results because you have to position the patient, and that patient who is in pain after pelvic injury is not going to achieve an optimum position and get the best possible radiological imaging. So patient selection may be affected by the imaging that is done. There's also inherent subjectivity in patient-reported outcome measures. Then the limited number of subjects in the study, and then the outcomes of urethroplasty are time-bound. The results tend to worsen with time. So I'm reviewing these results after 3 years, but if we do it after 5 or 7 years, the results might be somewhat different. Then, and like I've said, then there's this inherent error of imaging in acute setting. So in conclusion, I've addressed the issue of posterior urethral stenosis, which commonly affects a young segment of the population, and then they arise from pelvic fracture urethral injuries, and they are a common complication of pelvic fracture urethral injuries. And then we found out that these pelvic fracture injuries leading to stenosis are predictable, they are preventable, and they are a public health issue. And then because they don't lead to mortality, most of the time they cause significant morbidity, and therefore they are a quality of life issue. Prompt recognition, appropriate management, and individualized management for that matter is imperative. Thank you very much.
Thank you for that, Dr. Tele, for highlighting a preventable cause of strictures in young men. We'll move on quickly. We'll have less time for question and answers. The next person we have is Agneta Chelimo, a nurse working at Kenyatta National Hospital with over 21 years of experience. I am familiar with some of her previous work regarding predictors of wound sepsis in mothers post-cesarean section. But today she will be discussing discharge communication practices and patient experiences in the general surgical ward at Kenyatta National Hospital. I would like Mrs. Agneta Chelimo to start presenting. Thank you.
Sorry, thank you. Yes, I'm setting up my presentation. Sorry for that. I hope it is clear. Good afternoon, everyone.
We can see you and we can hear you. You may continue. Thank you.
Thank you. So Agneta Chelimo is my name, as you've mentioned it. Thank you very much. So today I'm going to share with you what we did in between last financial year as a research for the division healthcare quality, and it is about discharge communication practices and patient experience in general surgical wards, Kenyatta National Hospital. And my co-authors were Dr. Kutoi and Nancy Kashoki. So again, as the background of the study, We know that effective communication is very important, especially between the healthcare providers and the patients, so that we get patient-centered care at the end of it all. Again, care of late is very inclusive. We need to include the families so that at least we also get a very good outcome. And communication during discharge ensures continuity of care, as mentioned by the other researchers done in 2014. And again, enabling reliable care process between healthcare providers across the organizational lines. This is very important to do a communication, especially when you are dealing with the patient together with the relatives. Again, we realize that ineffective communication will automatically lead to medical errors and many a times adverse effects if you don't communicate promptly to the patient. Again, statement of the problem. We realize that poor communication during discharge results in poor health outcomes that I have mentioned, and it has been supported by the other researchers who have done earlier researches. And communication during patient discharge is still a major problem in KNS, as portrayed in Patient Affairs Unit, which is in Healthcare Quality Division. They normally do analysis of complaints, of all the complaints from patients. And we did this not basically because complaints came from surgery, but complaints are all over in the KNH. And so we realized that complaints are very high, especially when it was compiled in Q3, KNH 2019 at Patient Affairs. So again, we realized that scant information in patient discharge is giving a lot of problems, especially when it comes to continuity of care. So considerably, evidence of poor health outcomes among patients recovering from surgical treatments all across the world have been realized to be very poor. Again, for our general objective, we wanted to evaluate the influence of discharge communication practices on patient health outcomes in surgical wards at Kenyatta National Hospital. So our specific objectives were 4. We wanted to determine the practices of person-based discharge communication practices in general surgical wards in KNH. We also wanted to determine the practice of written discharge communication practices in general surgical wards in KNH, and also to determine the practices of IT-based discharge communication. And finally, to evaluate the influence of communication practices at the discharge on patient outcomes. So these are the research questions, as you can see. And the conceptual framework, we looked at the independent variables and the dependent variables as the 3 objectives, that is person-based discharge communication, written discharge practices, and IT-based. So our dependent variable was basically the patient health outcomes, which we were trying to look at whether there is any readmissions, continuity of care, how was the continuity of care, the safety of care, and the timeliness. So again, for the methodology, the research was basically descriptive cross-sectional research, and the population, we drew our population from the SOPC clinic 24 at Kenyatta National Hospital, where the inclusion was discharged patients from general surgery wards 5A, B, and D. And we had a sample of 180 patients. So again, the sampling technique was a stratified random sampling technique where we picked 180 patients. The data collection was same structures researcher administered questionnaire, which was both qualitative and quantitative. So the results are as follows. As you can see that there were many male patients, around 54%. And if you look at their ages, most of the patients who were admitted at that time and discharged home coming for clinic were above 55 years. As you can see, they are 40%. And we also had some patients who are below 30 years, around 18% of the patients. So for the results of written discharge communication practices, you can see that we were asking questions about whether they agree or disagree that the discharge communication practices were communicating and legible, especially the handwriting. So we realized that most patients, we didn't test their literacy, but many a times, most of our patients are literate, or even the carers, the patients, the people who come with them, they are learned people. So most of them actually answer that the unwritten discharge letters are very clear and good. Most of them disagreed, as you can see, 88%. So this brought about a gap that we needed to sit down and see how well we can be able to have a clear written discharge communication letters. And again, as you can see, most of them have said they are provided with a clear written information, instructions on what to do with the situation after discharge. Of course, 42% disagreed. So again, it is a gap that we need to ensure as a healthcare quality in our institution, that most of our clients are satisfied, because we know quality is meeting or exceeding the expectation of the customer. So again, these are narratives that most patients also informed the people who are collecting questions. So again, we grouped them into thematic areas, and you can see most of them also were really complaining that we can't be able to read and the handwriting. And again, most of them also mentioned that I don't know what to do in regards to home-based care. So it shows clearly that we are not very keen, especially sitting down with these patients and explaining to them exactly what is expected, what are the treatments after the care, what are you supposed to do after that, coming to the clinic and so forth and so on. So again, the person-based discharge communication practices, as you can see, it was again about agreeing or disagreeing. So the healthcare provider usually make physical personalized visits on checkup. Most of them agreed on that, 99%. This is very good, and we need to continue with the same spirit. And of course, they are saying, my relatives don't take me to hospital, it is beyond us to, but again, we need to communicate, even when we have the family informing them that we need to bring the patients to the hospital because this is a sick patient. So again, this is a narrative of the same. Most of them also complained, and most of them appreciated. They said my health has greatly improved. Others said, I got an emergency while at home, and when I called the doctor, he was rude to me. These are just the exact things that patients mentioned. And so again, some of them said the discharge process is exhausting. By being sent from place to place, most of them mentioned that they come and they don't know exactly where to start. So this shows us that we don't exactly explain to our patients. Most of them also mentioned that nurses are very rude. This is something that we need to take crucially, so that at least we communicate to our patients. Clients are our customers, and we need to meet their expectations every other time that they come to seek for our services. Again, for the IT-based discharge communication practices, of course, most of them said they disagree. There is nothing like IT-based discharge communication in KNH. And for that 10% that you see there, some of them say that we had relatives. They have relatives who work in the institution, and so they were able to remind them that tomorrow is your clinic day or next week is your clinic day. Otherwise, most of them said nobody reminds them. Again, the same narrative on the same. They're saying, I wish the hospital would communicate the appointments time. I was here at 5, so the doctor at 12. So those are things that we need as KNH to take note of that. And again, most of them also mentioned that the hospital should have a follow-up mechanism. And many of them also complained that the calls have helped me. But this is a positive answer, that the calls have helped me in diet check and proper mechanisms. So these are some of the narratives that the patients explained to the data collector. So again, for the patient outcome, we also had some of the questions that we grouped to show that there is a continuity of care, timeliness, readmissions, and safety of care. So again, you can see that in terms of continuity of care, 51% of them said it was poor. Again, for readmission, it was only 3%. And this is, however much small it is, the percentage, we needed to take note of that, because having readmissions, it means something went wrong. And we are geared towards ensuring that 100% of care is delivered and patients are so satisfied. And when discharged to home, they go and continue with the quality of care as our previous presenter mentioned. So again, for safety of care, we asked questions that do you fear for your life after discharge? And so most of the patients said yes. We don't even know whether we will reach the next clinic day. So again, this is something that we need to take note of it as an organization. So in conclusion, we are saying that person-based and written-based discharge strategies have been moderately utilized in discharge communication. Effective discharge communication practices have positive patient outcome, and follow-up communication, clear family, patient-family conference use for health information dissemination, regular and timely follow-ups have a positive patient outcome. So again, it is essential to encourage positive utilization of all the 3 discharge communication practices to improve efficiency and patient health outcomes. So for the policy recommendations, we are saying that we need to emphasize on patient follow-up and communication mechanism. Again, we need to encourage use of patient-family conference tool, which is available in KNH. Most of the wards or units are using it, but most of them have not used it fully. So we are encouraging for that patient-family conference tool to be used. Healthcare providers to standardize on the written prescriptions, discharge letters to enhance clarity and information relevance to both patients and their relatives. Again, we embrace on person-centered care and encourage KNH to use IT-based discharge communication. Otherwise, I needed to acknowledge the following, that we wish to appreciate the Department of Medical Research for funding this research, and we also acknowledge the following teams. The General Surgery Ward.
The microphone is unmuted.
Yes, there is a noise in the background. So we appreciate 5A, 5B, and 5D staff, Clinic 24, and research assistant and statisticians. Thank you so much. That is the end of my presentation.
Thank you so much for the presentation. A very interesting and succinct presentation. We have time for questions. We shall entertain any questions from the participants. Please feel free to type any question in the chat or in the question and answer section. We have 10 minutes for anything that you want to be made clear. And remember, there is no such thing as a bad question. It looks like, as they say, if there are no questions, either the presenters were very good or they were very bad that nobody understood. But as someone who was watching, I was quite impressed by both the presentations. Thank you both for your time and for your clear hard work. Please keep it up. It's inspiring for everybody else. Thank you.
Thank you. So our next moderator is Dr. Weru. Dr. Weru, are you in?
Yes, I'm in. Good afternoon. Okay, good afternoon. My name is Dr. Irene Weru. I'm a clinical pharmacist working at Kenyatta National Hospital. I think we'll go straight ahead. We are a few minutes ahead of schedule. our presenters for the afternoon, for this session, I can just see 2 online. So we are going to go straight ahead and start with the 2 who are online while we try to reach out to the others who are not yet online. So our first presenter for this session will be Doreen Nyak Matara. Doreen, I have seen you online, so be ready to present.
All right.
And Doreen is going to be presenting to us on phytochemical analysis and investigation of the antimicrobial and cytotoxic activities of croton dichogamous packed crude root extract. Doreen, please tell us, give us a brief background about yourself, and you have 15 minutes to present. Welcome.
Thank you so much, Dr. Weru. My name is Dr. Matara Doreen, and I am a pharmacist by profession. I'm also currently a student taking pharmacology and toxicology at the University of Nairobi, the College of Agriculture and Veterinary Sciences, Kabete. My presentation today is entitled Pharmacochemical Analysis and Investigation of the Antimicrobial and Cytotoxic Activities of the Crude Root Extract of Croton dichogamous. I hope you can see my screen.
Yes, yes.
All right, thank you. So this presentation has already been published by Hindawi Journal sometime this year. And my co-authors are Dr. Nguta Joseph, Dr. Musila Mtie Frederick, and Dr. Mapenei Isaac. We all can agree that antimicrobial drug resistance has been a problem in the public health. And in recent studies, we have seen an increase in antimicrobial drug resistance, which we project to cause a crisis in our public health if something is not done. Currently, we have seen long hospitalization, hospital stay, and sometimes treatment failure and mortality rates because of antimicrobial drug resistance. And this is very saddening. So we as the young scientists are out to look for new potent antimicrobial agents or to try and modify the ones which are available so that to can curb these crises. Now, luckily for us, at least research has shown that natural products and mostly plant-based antimicrobials can actually fight bacterial, fungal, protozoal, and viral diseases with minimal side effects. And apart from these plant extracts fighting the infectious agents, we've also observed from research that they can also, the derived products of these extracts can also act as synergists and potentiators of the existing antimicrobial agents. Now, the plant of study that we focused on is Croton dichogamous. It's a very common plant in Eastern Africa, in at least most of the counties in Kenya, and it's been used traditionally in the treatment of infectious diseases, though no documentation has been available about it, though mostly used in traditional medicine. It's also been seen to have some antimalarial effects. The traditional healers use it for that, and antipyretic as well as a pesticide in the Cumberland. It's used as a pesticide, and it's also been shown to have antitubercular effects. Sorry. This is a plant that I'm talking about. I'm sure maybe you have seen it. It's a very short shrub, mostly found in Kajiado and most of the counties, of course. And now the objectives of this study, we set out to evaluate the antimicrobial activity and the safety of the plant. So specifically, we were evaluating the antimicrobial activity using the acquired and organic root extract of these plants. We also determined the cytotoxicity and the phytochemical composition of the extracts from these plants. We extracted the plant material using acetone, distilled water, and 50% ethanol. And in testing for the antimicrobial susceptibility, we used two gram-positive bacteria, that is Bacillus cereus and Staphylococcus aureus. We also used 2 gram-negative bacteria in the testing, that is Pseudomonas aeruginosa and Escherichia coli. We also tested the extract on one fungal organism, that is the Candida albicans. We used agar-well diffusion technique and microbial dilution technique to test. Our positive controls were cephalexin and fluconazole for the bacterial and fungal organisms. And we also had negative control, that was dimethyl sulfoxide. In testing for the cytotoxicity studies, we used brine shrimp lethality assay. This is where we took the brine shrimp eggs. Brine shrimp is a pet food available in the pet stores. So we took the brine shrimp eggs and hatched them and used 1-day-old brine shrimps or napoli to test for the cytotoxicity of the extract. We took those napolis and placed them in the extract. We used biscrystine sulfate as a positive control. And after 1 day old, we checked the mortality rate. And those values which we found out, we used to document the lethal concentration value. Of course, we performed the phytochemical analysis to ascertain the composition, the phytochemical composition of the plant. And the results, we found out that the 3 extracts of croton dichogamas, the organic and inorganic, were having antibacterial activity against gram-positive bacteria, the B series and S series, and also there was antifungal activity shown by the 3 extracts. That was very positive result, but there was no antibacterial effect shown by the gram-negative bacteria strains of P. aeruginosa and E. coli, even at a concentration of 250 milligrams per ml, which was our highest concentration. The highest antimicrobial activity was demonstrated by the acetonic extract of B series, which recorded a zone of inhibition, the first one up there, of 17.33, and also it recorded MRC value of 10.42. That was the highest antimicrobial activity that we found. Of course, the others also recorded a good value, except the gram-negative bacteria. In the cytotoxicity assay, we analyzed the mortality rates using probe-bit regression analysis, and then we used the Meyer's criteria of toxicity to rate them. The LC in Meyer's criteria of toxicity, the lethal concentration values between 500 and 1,000 milligrams per ml were considered non-toxic, while values of lethal concentration values of 100 to 500 milligrams per ml were considered moderately toxic. Those values which were less than 100 micrograms per ml were considered highly cytotoxic. Now, the results showed out that all the extracts of croton dichogamas, the acetonic, hydroethanolic, and aqueous, were highly cytotoxic, with all of them having values of 100 micrograms per ml and below. This is the chart of how the mortality rates were. You can see at 1,000 micrograms per ml, all the extracts had 100% mortality rate, but in the second concentration, that is 100 micrograms per ml, acetonic extract was very high, in fact, higher than the reference drug, which is vincristine sulfate, a common anti-cancer drug. The confidence intervals of aqueous extract and hydroethanolic extract overlapped with that of vincristine sulfate. This is to show that there was no significant difference in the lethal concentration of vincristine sulfate and the 2 other extracts. However, the acetonic extract showed a very high a very high cytotoxicity, and in fact, it was higher than the vincristine sulfates, the one highlighted in red, acetonic extract, and the confidence interval was even too low than vincristine sulfate. That means its level of cytotoxicity is higher than the reference drug. In the phytochemical analysis, we found out that the plant had very potent phytochemical constituents. The flavonoids were present, the saponins, phenols were present, the tannins, terpenoids, anthraquinones, and polyuronides. These are very potent phytochemicals in the pharmaceutical industry. And in conclusion, in this study, we found out that the roots of croton dichogamas have very beneficial phytoconstituents, and they also possess a moderate antibacterial activity. However, only against gram-positive bacteria. In this study, we also found out that all the extracts of croton dichogamas were highly cytotoxic. That means we are dealing with a plant that can be a potential anti-cancer agent. Therefore, we had recommendations that isolation and identification of the active phytoconstituents should be done so that we can develop a future anti-cancer drug. We also noted that the locals use this drug for treatment purposes and as well as it's used as a pesticide. So we also recommended that maybe in the future studies, we could do a dose range study so as to ascertain the therapeutic effect of both cases as a pesticide and in treatment purposes. Thank you so much. That's the end of my presentation.
Thank you so much, Dr. Doreen Matara. That was a very interesting presentation. I think we are inspired. There is hope for the future. And I think it's going to be interesting to see that work taken to the next level. So we'll keep the questions to the very end. I'm looking out for the question and answer section to see if we have any questions. We don't have any yet. But for the participants, please put in your questions on the Q&A section and we will take them at the end. So our next presenter is going to be Dr. Joseph Mwanzia-Nguta. He was a co-author in the previous presentation that Doreen has just presented. And his presentation will be on bioprospecting against zoonotic Mycobacterium tuberculosis from natural products of plant biodiversity. Welcome, Dr. Nguta. You have 15 minutes to present.
Many thanks. Let me try to see if I can get on board.
Dr. Nguta, I propose we move on to the next presentation because it's a slightly shorter one, and then we can try and gather those slides so that we can redeem time.
No problem.
All right, thank you.
No problem.
All right, thank you. So we will, apologies for that, we will take our next presentation by Dr. James Kiamba Mailu on medicinal plants used in managing diseases of the respiratory system among the Luo community, an appraisal of Kisumu East Sub-County. Kiamba Mailu, you have 10 minutes to present.
Thank you very much, Daktari. My name is Dr. James Kiamba Mailu. I'm a pharmacist by profession. I also hold a Master's of Science.
Please move closer to your microphone. You're a bit low on volume. Thank you.
Is it better?
A little better. If you can make it louder, it would be good, but let's proceed. Give us a slideshow of your presentation.
I am sharing it. Is it visible?
It's visible. We would like it on presentation mode.
Thank you.
Thank you. Thank you. Proceed.
Thank you very much, Daktari. I'll be as brief as possible. My name is Dr. James Kiamba Mailu. I'm a pharmacist by profession. I also hold a Master's of Science in Pharmacology and Toxicology from the University of Nairobi. This was part of my MSc work. I did some work on medicinal plants used in managing diseases of the respiratory system among the new community. This was an appraisal of Kisumu East Sub-County. The others, including myself, Dr. Joseph Guta, Professor Musini Mbaria, and Dr. Michelle Okumu. So this work is already published in Chinese Medicine, which is a DMC. It was published last year. As a disclosure statement, this was not a funded project, and I sought approval from the Safety Animal Use and Ethics Committee in Nairobi. So the objective of the study was very simply to do a survey on medicinal plants used within the study locality. We sought first to identify illnesses, respiratory illnesses treated in the area. We also wanted to find out what were some of the plant species and plant parts used in preparation of herbal remedies for the respiratory infections stated. Then we also sought to identify remedies, how the remedies were prepared, and finally, what was the route of administration of these herbal remedies. So the study was conducted between March and September of 2019, and a combination of semi-structured questionnaires and interviews were conducted with the locals. Snowballing was used to identify a herbalist. This was done with the help of a taxonomist who was familiar with local flora and dialect. Out of this, we were able to interact with 30 herbalists, and language barrier was done or was helped with the aid of the taxonomist who was of the dialects of the locality. This is a table, a summary of the demographic of the study participants. We had a total of 26 female, which constituted 86.7% of the study respondents. The age distribution of the respondents ranged from 31 years to over 71 years of age, with a total of 3% of the study respondents being between the age of 61 and 70 years of age. In terms of educational background, 17 out of the 30 had no basic education, with around 9 respondents being of the age of 21 to 30 years of age. In terms of years of experience, they had practiced the trade for a period of 21 to 30 years of age. So that was plant collection in Kajulu Hills with the aid of the taxonomist and the local herbalist. So a total of 45 plant species belonging to 43 genera were collected. These were some of the sample specimens that were collected and deposited in the University of Nairobi herbarium. This is a plant Euclid ignorum, which was called by the local name Ochol. It was collected in Kajulu Hills. And that was done in April of 2019. Out of these plants that were collected, the dominant family was Cassiae and the Masai, with 5 species each. The identified plant species comprised of trees, with 4.4%, shrubs at 7.8%, herbs 8.9%, climbers and cones 2.2%. Majority of the plants were sourced from the wild, which accounted for 79.2%. 3 plants were the highly cited plants, with the Euclid ignorum, Pelosoma casablense, and the Carissa julis were the most cited plants in terms of their use in management of respiratory infections within the study locality. Majority of the plant parts used were leaves at 3%, roots 28%, and stem bark 24%. Roots, tubers, and root bark accounted for a total of 36%. The major route of preparation of the herbal remedies was decoctions, contributing to 68.8%, concoction 20.8%, and chewing 12.2%. Other methods of preparation included cold maceration and powdering. The main route of administration was oral. So based on the study, there was quite predominant use of roots, root bark, and root tubers, which threatened the ecological survival of some of the plant species. Majority of the plants were sourced from Kajili Hills, which is more or less forest where it was accessible to all herbalists, including myself. And due to this, we also identified some of the plants were no longer available. One of it was Wabugia salutaris, because of the lack of proper conservation practices. It was not available in the wild and now domesticated. Then we also saw there was a lot of need for medicinal knowledge in the study area. As we have seen for the demographic table, it was evident that majority of the herbalists were of advanced age, and the trade was not being taken up by the younger generation. There should also be need to conserve some of the medicinal plants documented. There were some herbalists who had undergone some trainings with regards to how to do or how to conserve or have good conservation practices, which was commendable. Then there was also a need to further scrutinize these medicinal claims. Because of interest of time, I was not able to share the fullness of the article. We were able to do a thorough review from literature. We were able to identify the previous reported medicinal use of these plants, and there was a lot of concurrence with their use globally with regards to their use in respective infections. We also did a review on previous work done with regard to the pharmacological use, and there was some relation and also toxicological data. So there was also an additional work done on this, which maybe I'll be able to share a little bit on phytochemical analysis and sensitivity study on 3 plants, Petium Genzi, Phytosia elegans, and Acanthus polystatus, which were mentioned here. So thank you very much, and I'll be brief as such.
Thank you so much, Dr. James Kiamba Mailu, for that interesting work. I think this session, we are really going to have a look at some of our available local resources. So these are very interesting presentations. If you have questions, a reminder to post them on the question and answer section, and we will take them at the very end. Dr. Joseph Mwanzia Nguta, I believe we are ready now to project. If you still don't have your slides, we can project them from the Secretariat.
Please go ahead.
Okay, so Secretariat, please project for us those slides, abstract number 45 for Joseph Mwanzia Nguta, and we can proceed.
Thank you. Many thanks. And again, I'm quite sorry for the inconveniences. You know, these is a term of kind of ICT, and at times we do have these technological challenges. Again, many thanks to the organizers, George Kinuthia, for inviting me to share my work with you this afternoon. And I will be talking about prospecting against zoonotic Mycobacterium tuberculosis from natural products of plant biodiversity. I'm going to pay special attention to Solanum tovum, a plant which is commonly used in West Africa against respiratory tract conditions. Please, next slide. Now, as William Mosley, we had the opportunity to live from 1849 to 1919. Canadian physician and to say humanity has but 3 great enemies: fever, famine, and war. And then he went ahead to say that of these, by far the greatest and by far the most terrible is fever, and basically this forms the backbone of my presentation today. Next slide, please. Now, tuberculosis is one of the oldest non-infectious conditions, but still it remains to be the second leading cause of mortality worldwide, with 2 billion individuals who harbor the latent infection. The mycobacterial strains have continued to develop resistance to the available conventional drugs. In addition, the anti-TB drug development pipeline is quite thin, and currently we have only one compound, the TBA354, in the first phase of clinical trial. Now, this underpins the search for novel anti-tubercular agents if the ambitious World Health Organization target of decreasing the TB incidence by 90% and mortality by 95% by the year of our Lord 2035 is going to be realized. Second slide, please. Now, fortunately, the natural products have continued to dominate the TB or tuberculosis drug development pipeline since the discovery of rifampicin in the year 1952, as evidenced by the presence of rifampicin in the second phase and the third phase of the clinical trials. Now, the current study aimed to evaluate or explore the antimicrobacterial activity, cytotoxicity of Solanum tovum. This is a plant which is commonly used in West Africa against respiratory tract conditions. In addition, we also sought to investigate the best predictor of the crude extract activity against the pathogenic Mycobacterium tuberculosis. Basically, this was occasioned by the fact that in the developing world, many institutions do not have the capacity, do not have the level 3 biosafety lab where anti-mycobacterial investigations are conducted. Now, how did we arrive at Solanum tovum? Library and online published data was carried out on medicinal plant species which are traditionally used against tuberculosis, so in patients with signs and symptoms of tuberculosis in West Africa. Now, Solanum tovum parts were collected, a voucher specimen prepared with the help of botanists. This was at the Center for Plant Medicine Research in Kwapong. This is the eastern part of Ghana. The ripe fruits, leaves, stem, and the roots of Solanum tovum were collected for the purposes of antimicrobacterial and cytotoxic investigations. Now, basically, this is a flow diagram showing basically the preparation, the collection of plant material, the drying, the grinding, extraction with solvents of different polarities to get the crude extract for the eventual tests. Next slide. Now, here I'm again demonstrating the methodology which we adopted. And this methodology was basically aimed at investigating, one, the efficacy of the Solanum tovum leaves and unripe fruits against pathogenic and non-pathogenic mycobacterial strains. For the efficacy studies, we did use the Risazuline blue test, or the microplate Alama blue assay, the Mamba bioassay, for the purposes of generation of the highest concentrations or the least dilutions, which were able to inhibit the multiplication of pathogenic and non-pathogenic mycobacterial strains. All this work was done in a level 3 biosafety lab in Noguchi Memorial Institute for Medical Research. Now, again, we did use the MTS assay while adopting the MRC5 cells from American type culture collection for generation of the cytotoxicity or the median cellular cytotoxicity levels. Now, both of these two indices, the median cell cytotoxicity levels and the minimum inhibitor concentration values, were used to generate the selectivity index values, which we did use as a guiding factor for further evaluation of the antimicrobacterial activity of the exciting part from this study plant. Next. And basically, these are the MIC values of the hydroethanolic extracts, which are derived from the Solanum tovum. And basically, bringing on board the unripe fruits from Solanum tovum, mainly against the fast growing Mycobacterium aurum strain, the slow growing Mycobacterium bovis BCG strain, and the pathogenic strain, the Mycobacterium bovis strain. And definitely we were able to show that at 19.5 micrograms per ml, the crude extracts from the unripe fruits of Solanum tovum were in a position of inhibiting the multiplication of Mycobacterium BCG strain. Now, of course, we had our positive controls, the isoniazid, rifampicin, which obviously were at better activity than the crude extracts, which were isolated. Next. Again, we also, just go back. Yeah, we are looking at the median cellular cytotoxicity in microgram per ml of the crude extracts. Just go back. Go ahead. Move ahead, please. Next slide. Next. Yes, there. So here we are showing the safety. We are basically showing, we are asking the question, how safe are these crude extracts? Are they exhibiting selective toxicity against the mycobacterial strains? Again, we are using the IMRC5 lung fibroblast cells isolated from a 5-month-old kid and deposited at the ATCC. And you can actually see from these results that all the extracts that we tested exhibited selective toxicity against the mycobacterial strains as shown by the selectivity index values. Of worth noting is the SI value from the leaves of Solanum tovum of 1602, which was far much better than the SI value of the current used anti-tubercular agent, isoniazid. Let's move forward. Next, please. And again, as I did indicate, our next objective was basically to look at the best predictor of the pathogenic mycobacterial strain, the best predictor of crude extract activity against the pathogenic mycobacterial strains. This is for one reason. Many of the labs in the developing world do not have the capacity to conduct antimycobacterial evaluation of pharmaceutical formulation because they do not have the BSL3 laboratory. Now, we did look at the correlation, generate the correlation coefficients of the activities exhibited by the crude extracts against the M. bovis, the pathogenic strain, and the vaccine strain of the Mycobacterium bovis. And here, the regression coefficient was 0.127, which was not very good. And at this point, I really was not happy with using the M. bovis, BCG, as a predictor of the crude extract activity against mycobacterial strains. Next, please. Now, the second figure, the second figure again shows the correlation coefficient of the slow or fast-growing Mycobacterium aureum strain vis-a-vis the pathogenic Mycobacterium bovis strain, and the regression value was far much better than the regression value that we have just seen, being 0.284. At this point in time, I did recommend, and we continue to use Mycobacterium aureum as a predictor of pharmaceutical formulation activity against the pathogenic strains of Mycobacterium. We can easily use this strain in our level 1 and level 2 labs, which we can easily access. Next. Next, please. Again, this is a correlation again of M. aureum again vis-a-vis the bovis BCG strain, and you can now see exciting correlation coefficient. And again, a clear testament that use of Mycobacterium aureum can well predict the activity of pharmaceutical formulations against against the pathogenic mycobacterial strain. Next. In conclusion, our study did demonstrate at this point in time that the unripe fruits collected from Solanum tovum did demonstrate moderate antimycobacterial activity against the pathogenic strain Mycobacterium bovis. Now, the leaves, again, another exciting finding was that the leaves from Solanum tovum and the most promising SI index value of 1602. And I have to point out during this meeting that I went ahead and carried more work toward the isolation and characterization of the bioactives from this part of Solanum tovum. I'm sure I'll be presenting the outcome of that work in another meeting. Now, the crude extract activity against the Mycobacterium aurum was the best predictor of activity against the pathogenic Mycobacterium bovis strain with a correlation coefficient of 0.2864. And ideally, I did recommend and we continue to use Mycobacterium aurum, a fast-growing strain of Mycobacterium, as a predictor of pharmaceutical formulation activity against Mycobacterium pathogenic strains of Mycobacterium. Now, the current study has gone ahead to validate the ethnopharmacological utilization of Solanum tovum, different parts, in the West African ethnobotany against illnesses which closely resemble tuberculosis. And I do recommend the further studies towards the search of novel anti-tubercular agents. We did push this study forward, and many analogs of the isolated compound solaginine are being tested in collaboration with the Institute for Tuberculosis Research and the Esilia Open Lab in Spain. Next, please. Yeah, and yeah, basically, I do acknowledge the many people who did participate. You can just go to the next slide, please. Just move. We are just acknowledging the Bill and Melinda Gates Foundation for financing this study, and the program director of Quadro Coram, the advisory board members, exciting research assistants, Abena and Henry. They are exciting in the biosafety level 3 lab, genomics, Guy, Isaac, the center at the Center for Plant Medicine and Research, Eastern part of Ghana, the Noguchi community, University of Nairobi, my family, and not but not the least, the Almighty God. Questions, please.
Thank you so much, Dr. Nguta, for that very exciting presentation. As I said earlier, I think this section that had the medicinal plants presentation gives us a lot of hope in terms of utilizing our local resources in treating diseases. And I have not seen a question yet. We hope that before the end of the this session, we will get some questions. So I haven't seen Levi Wanjiro Mwangi online unless you're using a different name. Please send me a message if you're online. We will move on to the next presentation by Anthony Mushai Manyara. I have seen you online. Please set up your presentation. So Anthony Mushai Manyara will be presenting to us understanding the etiology of type 2 diabetes and lived experiences of diabetes risk in Nairobi, Kenya. Anthony Mushai Manyara, welcome. Give us a brief introduction of yourself, and then you have 15 minutes to present.
Okay, thank you. Can you hear me?
Yes, we can. Please give us a slideshow or a presentation mode of your slides.
Okay. Is that fine?
That's fine. Thank you. Proceed.
Okay. Thank you. So, hi everyone. My name is Anthony Manyara. I'm a PhD student at the University of Glasgow, and also I'm affiliated to the Technical University of Kenya. And I'll be presenting part of my PhD work on understanding the risk factors of type 2 diabetes and the lived experiences of diabetes risk. So type 2 diabetes is on the rise in Sub-Saharan Africa, and the prevalence is expected to double by the year 2045 if prevention measures are not taken. It is a preventable disease, and we can target modifiable risk factors, and the common ones are weight, diet, and physical activity. But there's emerging evidence that other risk factors could also play a role in the development of diabetes, such as muscle strength, sleep, and the early life environment. As we think about prevention, it's important to note that although the Kenya Diabetes Prevention and Control Policy documents are well aligned to international documents, they are based on scant local evidence. And so there is need for us to conduct studies in Kenya and in Sub-Saharan Africa to understand the etiology or the risk factors of diabetes for us to put in prevention measures. So we did a case control study in Nairobi, where we recruited 70 type 2 diabetes cases, who I call cases in the course of this presentation. And we matched them on a ratio of 1:1 to controls. And we matched on age, sex, and socioeconomic status. So this sample had an 80% power to detect associations between exposures with a prevalence of 30% in the general population and diabetes at an odds ratio of 2.7 at 0.05 significance level. So we included people who had lived in Nairobi for at least 5 years, who were aged between 35 and 64 years, who didn't have a health condition that would influence cardiometabolic health, such as HIV. And our cases had to be recent, so they had been diagnosed in the last 2 years. So we collected data using questionnaire, and also we did measurements such as hand grip, anthropometrics, and body composition. And we analyzed our data using a logistic regression model, and that was adjusted for covariates. So in this table, I present some of the results that we had. And as you can see, there is controls disaggregated by sex, so women, men. And then there are cases disaggregated by sex, women and men. And then we have the odds ratios. The first odds ratio is adjusted for social demographics, and the other one is fully adjusted for all covariates. So the odds ratios that are significant are bolded. So the first finding that we found is that the cases were shorter than the controls. We didn't find differences between percentage body fat mass, and BMI between the cases and the controls, but we didn't find a difference between waist to hip ratio, which is a measure of central obesity between the cases and controls. So the cases were more centrally obese than the controls. And then we did find a difference in the fat-free mass, which is a measure of muscle mass between the cases and controls. So the controls had more muscle mass than the cases. And then lastly, we did find difference between the controls and cases in terms of hand grip strength, which is a measure of muscle strength. So the controls were stronger than the cases. And so more muscle strength and more muscle mass was associated with lower odds of type 2 diabetes. So this was a mixed method study. We also did a qualitative case study, and this was done in 2 communities. So we had a middle income community, that is Buruburu, and a low income community, that is Mukuru. And we recruited about 15 participants in each of these communities with a mean age of 41 to 44 years. The first interviews were face-to-face, and then the rest of the interviews were on telephone due to COVID restrictions. The in-depth interviews were transcribed, translated, and thematically analyzed. So one of the findings we found from the in-depth interviews related to the barriers to preventive measures was that there were knowledge gaps on diabetes risk factors, mainly in the low-income community, that is Mukuru. As you can see a quote here from a community health volunteer, she says, "I've not done that research to understand what causes diabetes. For my side, I would not explain much about diabetes in depth on getting diabetes. For sure, I would not. I don't know much about diabetes in depth." So there was lack of knowledge about what are the risk factors of diabetes, and mainly in Mukuru. The other barrier was that there was a low disclosure by people with diabetes in both communities, and participants felt that these may have impeded increase in knowledge on diabetes in communities, because when people open up that they have diabetes, then more people are willing or are able to learn more about diabetes and what causes it and how we can prevent it. Then in Mukuru, there was also a low perceived susceptibility in people felt that they were not susceptible to diabetes, which could be a barrier to taking up preventive measures. So we also found other barriers to preventive measures being diabetes screening, and diabetes screening is important because you could detect prediabetes early and put up preventive measures. And so there was limited access to screening, mainly in Mukuru. And also when screening was available, some participants did say that there was fear of positive diagnosis due to high cost of diabetes management. So some people would shy away from going for screening, even if it was available and accessible. So as this housewife from Mukuru says, in my opinion, not many people have gone for testing because of fear. You can find a person going to test and then you find that you have it. You see, now that is a problem that that has come in, and you start thinking, now I have this disease, what will I use to treat it? I do not have money. So many have failed to go to test because of that fear. So what are the implications of our findings? So from our case control study, we can imply that central obesity measures rather than BMI should be used for risk stratification in Kenya, and also they can be used for intervening. So we should intervene to reduce central obesity even when people have a normal weight. So as our data showed that for men, the average or the mean BMI was normal weight, but our cases or the people with type 2 diabetes were more centrally obese than their controls. Then another implication of our case control findings is that we can use interventions that increase muscle mass and strength to reduce the risk of diabetes in Kenya. And just to mention that the recently launched WHO physical activity guidelines recommend muscle strengthening activities at moderate or greater intensity at least 2 days a week for additional health benefits. Just to mention that our case control was published recently, and you can find more, we present more findings about that study and also more implications and the limitations of our study in that article. For the qualitative case study from the in-depth interviews, the implications that we can get is that we need to educate people on diabetes risk factors and personal risk, and especially in low-income settings. We need to increase community awareness of diabetes by supporting people with diabetes to disclose their condition. So this is one way that we can increase knowledge and awareness about diabetes in the community if people with diabetes are able to disclose their condition, and so people can learn more about diabetes. Then lastly, we can increase access to diabetes screening and affordable diabetes management so that to alleviate or reduce the fear associated with a positive diagnosis. And that is it. I would want to acknowledge the study participants, community mobilizers, and my supervisors. Thank you so much. If there are any questions, I'm happy to take them.
Thank you so much for that presentation. Very interesting what you have done. I have one question. We have a presentation that we may not be able to have, the one by Mary Wanjiro Mwangi on formulation of dispersible isoniazid. I have not seen her online, so I will proceed with the questions. We have one question from Professor Osanjo. Excellent work, Dr. Nguta and team. Regarding the work you presented, is Solanum tavam available in Kenya? If not, shouldn't we be actively investigating related and locally available Solanum species as possible sources of anti-TB drugs? Dr. Nguta.
Yeah, many thanks, Prof. George. And George, you know, we're in this game together. Now, yes, our natural product research team in the Department of Public Health Pharmacology and Toxicology, University of Nairobi, is quite excited about really investigating the safety and efficacy of locally used herbal preparations or medicinal plants in an attempt to come with useful cures for the many illnesses that we have. I continue to remind my students that over 70% of the drugs in clinical use were discovered following leads from ethnopharmacology. Now, thank you, Osajo, coming direct to your question, is that really Solanum tovum is not, does actually not grow in East Africa, in Kenya and in East Africa. I have a lot of it. I am in an active collaboration with my investigators at Nongushi Institute for Medical Research in the University of Ghana. So as far as I'm concerned, I have a lot of it. I have a lot of it. And I'm again trying to cultivate. I'm actually working very closely with the agronomy and the botany guys in our next department in Lamart to try to see if we can grow the Solanum tovum in this country. And yes, Professor Sajo, we should actually, and this is a task that you have given me, that I also need to look at other species of Solanum which are rarely available in our country in terms of looking at the activity against mycobacterial strains. That's a challenge which I take very positively, Sergio. And next time you'll see my presentation on the same. Really looking at the available Solanum species in this country and the activity against tuberculosis. But again, I have to remind you, Prof, that we basically build on the knowledge from our local people, which has been accumulated over many years. So that is one of the reasons as to why we may really not get into a fishing expedition evaluating the activity of all the Solanum species in our country. That's one of the barriers, and that's why I'm really trying to see if I can grow Solanum tovum in this country. For us to really to go ahead and get to the lab, carry out in vitro and in vivo studies, we have to get this information, this ethnobotanical utilization of the plant that we are testing from the local community. Because alone, that indicates that clinical studies have been carried out. These people have continued to use this plant for many years. They have shown it to be safe. They have shown it to be active. Actually, that is a guiding factor as to what medicinal plant we are going to move forward in our investigations. Many thanks, Prof.
So thank you so much, Dr. Nguta, for your response to that question. Our apologies that our program captured our next presenter as Mary Wanjiru Mwangi, but we would like, we have a correction. Our presenter on abstract number 19 is Martha Wanjiru Mwangi. We will give her an opportunity to share her presentation on formulation of dispersible isoniazid pyridoxine fixed dose combination tablets for isoniazid preventive therapy in pediatrics. Our apologies and most welcome, Martha.
Sorry, Dr. Weru. Can I respond to another question before I am actually in a lecture and I have another question in the Q&A? With your permission, please.
All right. All right, apologies for that. So as Martha sets up her presentation, Dr. Nguta, you can respond to the question on whether you use crude or raw extract. Please make it brief. Thank you.
Many thanks, Ezekiel. Okay, did you use crude or raw? I actually used crude. As I did say, I used 70% hydroethanol. We did demonstrate in our lab that 50 and 70% hydroethanol is capable of extracting all the antimicrobial bioactives from natural products. Many thanks, Ezekiel. Many thanks. Well, I have to rush to a lecture, and thank you for the organizers for giving me this opportunity. I'll be joining you later. Many thanks.
All right. Thank you so much, Dr. Nguta, for that work. We will release you. We can take the presentation from Martha Wanjiro. I hope, Martha, you're able to share your screen with us. Martha, the share screen button at the bottom of your icon. Or Secretariat, if you have the presentation abstract number 8, you can help us to share it. Martha, please unmute yourself and let us know if you're able to share your slides. Martha Wanjiro, please let us know if you are able to share your slides. You're a co-host now, so you should be able to do so.
Hello, hello. Yes. Now, where am I supposed to share?
As Martha is looking for that, we don't have any more questions. For the participants, you can still type in your questions in the Q&A section, and we'll be able to take those questions. Secretariat, please help us with the presentation from Martha, abstract number 8. Martha, you have 10 minutes. Please go ahead and make your presentation. Thank you. Martha, you're still muted. Please unmute and make your presentation.
Okay.
Thank you. Go ahead.
Okay. Good afternoon. My name is Martha Mwangi, a pharmacist currently practicing at Chuka Referral Hospital. This study was done in 2017 and published last year, July 2020. So I'll be presenting to you formulation of dispersible isoniazid pyridoxine FDC tablets for isoniazid preventive therapy in pediatrics. Next, please. Next slide. Okay, just a bit of a background. Go to the previous slide, please. The second slide. Yes, just a bit of the background. Okay, normally formulation scientists face challenges when formulating PIDS formulations because of the way pediatric gain weight. Go back, please. Go to the second slide. Yes, and liquid formulations are preferred, but they have limiting factors. For example, taste masking, bulkiness, and special storage conditions. And this is what led to the formulation of the FDC. And WHO normally recommends development of solid dosage forms that are pediatric friendly. And in this case, mostly dispersible tablets. And in a situation where more than one drug is used, it's advisable to use fixed dose combination. Next. Okay, TB, the fixed dose combination that was formulated was to prevent TB disease. So I'll present a bit of a background on the TB. It's one of the killer diseases in children, and it's classified into two. We have latent and active, and latent TB is managed by administration of isoniazid for at least 6 months. And since isoniazid causes peripheral neuropathy, pyridoxine is given to prevent, or rather to counter, peripheral neuropathy. And in Kenya, there is no pediatric-friendly dosage, solid dosage formulation for isoniazid preventive therapy. Hence the need to formulate the IPT. The objectives. The first objective was to come up with a target product profile for the IPT, in this case isoniazid and pyridoxine, to carry out the drug and drug excipient compatibility studies. And this was done using Fourier transform infrared spectroscopy to evaluate the powder blend before direct compression, and to formulate the FDC using a combination of 2 super disintegrants in different ratios, and then to evaluate the quality of the formulated FDC, the fixed dose combination. Next, please. The significance of the fixed dose combination will enable accurate dosing, will reduce the pill burden since the 2 drugs are fixed, they are together, and will increase the shelf life as compared to the extemporaneous preparation. Normally in the hospitals, when a drug is not available, we formulate extemporaneously. Next. It was an experimental lab-based study, and the study location was at the School of Pharmacy, that is the Pharmaceutics and Pharmacy Practice Lab, Pharmaceutical Lab, Chemistry Lab, Daru, and National Quality Control Lab. Next. These were the raw materials that were used. We have the isoniazid and the pyridoxine. They were the active ingredient, or the active pharmaceutical ingredient. Microcrystalline cellulose was used as a binder, mannitol as a filler, cross-camelose, sodium, cross-povidone, and sodium starch glycolate were the super disintegrants used at different ratios. Magnesium stearate was used as a lubricant. Colloidal silica anhydrous was used as a glidant. Sodium saccharin was used as a sweetener, and strawberry flavor was used as a flavor. Next. The equipment used in the study were the Fourier transform infrared spectrophotometer, the single station automatic tablet press, weighing balance, dissolution machine type 2, electronic tablet hardness tester, friability tester, UV spectrophotometer, and disintegration apparatus. Next. Then the target product profile was set. Pre-formulation studies were done. That is the drug excipient compatibility studies, and also the evaluation of the powder blend before the compression. And each of the ingredients was sifted using a 710 micrometer sieve. Then the powder blend per batch was prepared by first mixing the 2 APIs with the excipients. Each batch had 2 super disintegrants at different ratios, and then the blend was directly compressed to produce tablets. Next. So this table shows how different super disintegrants were used. We had 9 batches, and the disintegrants were used in different ratios as per the table. Next. Then the target profile, product profile was set as below. The dose, potency, the dose was once a day. Potency was 50 mg, stroke 6.25 mg, that is isoniazid 50 milligrams, and pyridoxine 6.25 milligrams. The formulation was dispersible tablets. The appearance, smooth tablets consistent in appearance. Identity, positive for isoniazid and pyridoxine. The assay done, we were expecting the quantity of isoniazid to be between 90 to 110%, pyridoxine 95 to 115%. Weight uniformity and content uniformity was to meet the USP, that is United States Pharmacopoeia standards. Disintegration, the tablets were expected to disintegrate within 3 minutes. And for the dissolution test, the tablets were to contain not less than 80% within 45 minutes of isoniazid and not less than 75% of pyridoxine within 45 minutes. Next. So these are the results, the isoniazid spectrum and the pyridoxine spectrum. Next. And then this is the spectrum for isoniazid and pyridoxine. Next. So for the physical tests that were done, angle of repose was done, compressibility index and Hausner's ratio. And from the table, we can see batch 2 to 5, for the angle of repose, it was good. 6 and 9, it was excellent. Next. So we had the weight uniformity test and the hardness and friability test. We can see on the table for the weight uniformity test, the weight of the tablets, the list was batch number 9, which was 120 milligrams. And for the hardness and friability test, we can see batch number 2, 3, and 9 passed the friability test because they were less than 1%. Next. So for the disintegration test, this was captured in seconds and all the batches were disintegrated. The tablets for all the batches disintegrated within 3 minutes, sorry. Next. So for the assay, we only batch number 9 complied. That is, it had 96% of isoniazid and 95% of pyridoxine. Next. So because it's only batch number 9 that complied with all the tests, we proceeded to do dissolution test just on batch number 9. Next. So from the discussion, this is the discussion from the drug excipient compatibility studies, the API, that is the active pharmaceutical ingredients, and the excipients didn't show any incompatibility. And the powder blend for batches number 2, 3, 4, 5, 6, and 9 portrayed good flow. And the target tablet weight was set at 125 and milligrams, and all the batches complied with the British Pharmacopoeia specifications. And batches 2, 3, and 9 complied with the BP specifications on friability test, that is less than 1%. And all the 9 batches disintegrated within 3 minutes. Next. So for the assay, only batch number 9 complied with the United States Pharmacopoeia 2017 of having isoniazid of between not less than 90% and not more than 110%, and not less than 95% and not more than 115% of the label amount of isoniazid and pyridoxine, respectively. For content uniformity test, tablets batch number 2, 3, 5, and 9 complied with the USP 2017 requirements. For the dissolution, batches 2 and 3 and 9 complied, but now we were concentrating on batch number 9 since it's the only one that had passed the assay test. Next. So for conclusion and recommendation, conclusion was that the set target product profile was achieved on batch number 9, and cross-camelose sodium and sodium starch glycolate, those are the super disintegrants, can be used to successfully formulate isoniazid pyridoxine fixed dose combination dispersible tablets. So for the recommendations was that stability test needs to be carried out, since this was not carried out because of time, and hydrophilic lubricant could be used to increase tablet hardness, and colloidal anhydrous silica should be increased in order to have good powder flow. Next. So those are the references, and thank you very much.
Thank you so much, Dr. Martha Mwangi. We appreciate that presentation. I was just listening to that presentation and wondering to myself why we have not increased our local manufacturing capacity yet, especially driven from the School of Pharmacy. But I think from the presentation this afternoon, there is again a lot of hope for us. We have local resources we can use, not just in our country, but within the African continent, as well as hope for increasing manufacturing capacity from these presentations. I don't see questions. I don't know if we have anyone who has questions for this team. Maybe I'll start by asking Dr. Mwangi a question. Do you have plans to take this work to the next level, like have large scale, take it to large scale manufacturing and be able to have large scale production of these dispersible tablets? What's your plan moving forward?
Okay, yes, I do have plans. But currently being based at the hospital, it's a bit tricky, but yes, I have plans.
Okay, thank you. So we hope that you should be able to collaborate with some of the local industries and be able to take that work to another level. Yes. I don't see other questions. Thank you so much for your presentation. I think we don't have any more questions, and I would like us to, from wherever we are, just appreciate our afternoon presenters. They have done a fantastic job. I think from the session that I was moderating, it is clear that there's a lot of work going on in terms of research in medicinal plants and related products. And we also have seen a presentation on diabetes. So there's a lot of work going on from our very own people. And we just would wish to applaud the presenters and researchers from this afternoon session and to encourage them to take this work to the next level. So the next session from here is the poster session. I don't know if Dr. Mongeli is online. I do not see her online, but we would like to welcome all the participants. There is the link to the poster session has been posted on the chat, and you can follow that link and view the posters. We encourage you to view the posters. We had a lot more presentations and abstracts sent in. Many of them are in the poster session, so please go into the poster session and be able to just look at these posters and encourage our researchers. Unless we have any announcements from Dr. Osanjo, Professor Osanjo and team, I think we are done for this afternoon session. Professor Osanjo, any more additional comments for the afternoon?
Thank you, Dr. Weru, and just to thank again our presenters. It's been great today. And tomorrow is our final day. So, and there's a poster session has already been announced by Dr. Weru. So we continue on to the poster session. Tomorrow we are beginning 1 hour earlier at 10 a.m. because one of the presenters, I think some of the presenters are presenting from a different time zone. So we request you to please join us 1 hour early, and then we go up to the finishing. It's our last day. So we hope to see all of you. So we thank you very much, and that will be it for today. Unless also, you know, we are here several, we also have the ICT team. So in case there's any other issue that is pending, then they can also indicate to the members of audience. But otherwise, thank you very much. See you tomorrow at 10 a.m., 1 hour earlier than usual. We are beginning 1 hour earlier at 10 a.m.